It's time for another warm-up. Let's get going. Now, which personality disorder best fits each of the following statements? So first we have excessive need to be taken care of, submissive and clinging behavior that's going to be dependent. Low self-confidence, fears of separation and losing support, also dependent. Grandiosity, feels he is entitled to things, lack of empathy, that's going to be narcissistic. Suicide attempts with high mortality, unstable mood and behavior, this is going to be borderline personality disorder. Next, what is the WAGR complex? So this is actually a mnemonic for things that you see with Wilms tumor, that renal tumor of early childhood. So W is actually for the Wilms tumor. A is for aniridia, where the iris is congenitally absent. G is for genital urinary malformations. And then R is for retardation, mental and motor retardation, or intellectual disability is what we call it now. All right, that brings us to the end of the warm-up. Let's get to that lecture.
In this video, we're kicking off the hematology section, starting with coagulation. Now, we're deliberately separating the clotting factors from the role of platelets in hemostasis for now, so you don't get them too mixed up in your mind. But before I get too far, the highest yield thing about hematology is the softball, classic presentations of diseases. A lot of students tend to freak out about hematology because there are all these different types of anemia, and the clotting cascade is so complicated, and it seems like there's a million different types of leukemia and lymphoma. But the complicated, detailed stuff isn't nearly as high yield as the softball stuff, the classic presentations. So from this video, you need to have a good understanding of the big picture and know a few basics about clotting factors, but you do not need to memorize the entire coagulation cascade. Remember, focus on the basic stuff. You're likely to see softballs, no fastballs, no curveballs, just softballs with hematology. Now, you may not need to memorize the coagulation cascade, but you do need to understand how it all works. So where do all these coagulation factors come from? Come from the liver, right? So the liver makes coagulation factors. And when your liver is diseased, like a patient with cirrhosis, it doesn't make coagulation factors, which is why with cirrhosis, in patients with end-stage liver disease, you end up with a high PT and PTT because the patient doesn't have the coagulation factors. On the left is the extrinsic pathway using factor 7, or the new name for the extrinsic pathway is the tissue factor pathway, because tissue factor is what kicks this off. When you have a tissue injury, tissue factor is released from those injured cells, and that triggers coagulation. The other name for tissue factor is thromboplastin. And then the other pathway is called the contact activation pathway, or the older name is the intrinsic pathway. This starts at the top with factor 12. And for all these, remember that the A form is the activated form. So in the intrinsic pathway, you have 12, which cleaves to 12A, and that converts 11 to 11A, and then 9 to 9A. Now what happens if you're deficient in factor 9? Well, that's hemophilia B. So hemophilia B is a deficiency of coagulation factor 9. Then factor 9 goes to factor 9A, and that's used to generate factor 10A, and this process uses factor 8A. Now factor 8 and factor 5 are your accelerating factors. And if you're deficient in factor 8, what disease is that? That's hemophilia A. So you can remember the difference between hemophilia A and hemophilia B pretty easily if you remember that A sounds like 8 for factor 8, and B goes with 9, like benign, B9. So 8 for hemophilia A and B9 is hemophilia B. And since both of these factors work together on the same step of the cascade, the clinical presentations of hemophilia A and B are pretty similar. Now what's the rate limiter of the coagulation cascade? It's actually the convergence of the extrinsic and intrinsic coagulation pathways at factor 10. We mentioned that factor 8 and factor 5 are your accelerating factors. There are specific substances that inhibit your accelerating factors, and those are protein C and protein S. So the coagulation cascade is pro-coagulation, and by inhibiting that with protein C and protein S, you break down clots. Well, guess where protein C and protein S come from? They also come from the liver. And in the next video, we're going to talk about how the anticoagulant drug warfarin inhibits the generation of several coagulation factors, specifically factors 2, 7, 9, and 10. But it also inhibits the production of protein C and protein S. So by inhibiting the coagulation factors 2, 7, 9, and 10, warfarin will inhibit coagulation and reduce clot formation. But by inhibiting protein C and protein S, warfarin transiently increases clot formation. And unfortunately, warfarin inhibits production of protein C and protein S more rapidly than it does the clotting factors. So because of this, when you give warfarin, patients actually become transiently hypercoagulable because you're inhibiting protein C and protein S first, and that's normally going to inhibit factor 8 and factor 5. So this is why when we start warfarin, we usually start heparin for a few days as well to overcome that transient hypercoagulability. So moving on here, you go from prothrombin, which is factor 2, to thrombin, which is 2A. which then converts fibrinogen to fibrin monomers, and then these fibrin monomers form a cross-linked fibrin mesh. This part of the cascade with thrombin and fibrin is called the common final pathway. This is where the tissue factor pathway and the contact activation pathways merge. So what substance inhibits thrombin from generating fibrin? Antithrombin inhibits thrombin. That's obvious from the name. Now the older name is antithrombin 3, so you may see that sometimes. So again, antithrombin inhibits thrombin from activating fibrin. So would antithrombin be a procoagulant or an anticoagulant? Well, thrombose means clot, so antithrombin is an anticoagulant. And there's a substance that basically increases the effectiveness of antithrombin, and that substance is heparin. That's how heparin works. It inhibits thrombin. Besides thrombin, there's something else that can convert fibrinogen to fibrin, which is the bacterial enzyme coagulase. So Staph aureus makes coagulase. That's how coagulase causes coagulation. Now you may also want to know that the cross-linking of fibrin to form that fibrin mesh is a covalent process. Those are covalent bonds. And you'll also note that several of these steps in the coagulation cascade require calcium and phospholipids. You don't need to memorize which steps they are, but I would know that calcium is essential for the coagulation cascade to work. You have to have calcium. If you put a calcium binder into the system to bind up all the calcium, that's going to decrease coagulation. Now we use calcium binders like trisodium citrate or EDTA in blood collection tubes and transfusion bags to keep the blood in there from clotting. So those are the basics of the coagulation cascade. Now let's go back and talk about the role of the kinin pathway and the fibrinolytic system in all of this. So at the top of the intrinsic pathway you have factor 12. We said that factor 12A activates factor 11. But factor 12A also has a second function, which is to convert prekallikrein to kallikrein. Then kallikrein cleaves plasminogen to form plasmin. And plasmin is a clot-busting substance. So plasmin breaks down the fibrin mesh in blood clots. So factor 12 is kicking off both the coagulation cascade and the fibrinolytic system, because you don't want to have either of these systems running amok. That could be dangerous, to start clotting everywhere or to start lysing clots everywhere. So this whole process needs to be tightly regulated. In the next video, we're going to talk about some clot-busting drugs that facilitate the activation of plasmin, drugs like streptokinase and TPA. So that's one important function of kallikrein. But what else does kallikrein do? Well, it also converts kininogens to kinins. Specifically, it converts high molecular weight kininogen, or HMWK, to bradykinin. Bradykinin has three functions. It acts as a vasodilator, it increases vascular permeability, and it's also a mediator of pain. Now, that sounds an awful lot like an inflammatory process, doesn't it? Well, the point I'm making is that coagulation and inflammation are interconnected. Inflammation promotes coagulation, and coagulation promotes inflammation. We also mentioned bradykinin when we talked about the ACE inhibitors, because angiotensin-converting enzyme, or ACE, is responsible for degrading bradykinin. And bradykinin can cause angioedema in patients who are taking ACE inhibitors. Since we have a little bit of time to spare, I want to briefly go over a couple of lab tests that we use to measure a patient's ability to clot. Now, I don't know that you're going to see this on step one, but it's very helpful to understand the difference between a PT and a PTT and a bleeding time before we start talking about these coagulation disorders, because the tests we order are going to help you point toward one diagnosis or another. And then last year we had several students asking us to explain more about these tests. So the prothrombin time, or PT, is measured by taking some of the patient's plasma and you add tissue factor, then you measure how long it takes a clot to form. And normally it's going to take 10 to 13 seconds. So PT is testing how effectively tissue factor can activate the tissue factor pathway and the final common pathway. So you're testing factor 7, 10, 5, and prothrombin, which is factor 2. Now, there's a lot of variability from lab to lab with regard to what the normal values are. So to compensate for that variability, the PT is always reported with something called an international normalizing ratio, or INR. So an INR of 1 is normal. Anything higher than 1 means that the patient's blood is taking longer than normal to clot. Then the partial thromboplastin time, or PTT, is measured by taking the patient's plasma again, and you're adding material that activates the contact activation pathway, something like silica. Then you're going to measure how long it takes a clot to form. Normally, PTT is around 25 to 40 seconds. But you also have to add some phospholipids that normally combine with tissue factor to form thromboplastin. But we're not adding the whole thing. We're not adding thromboplastin. We're just adding the phospholipid part. So this is the partial thromboplastin time. So PTT is testing the function of the contact activation pathway and the final common pathway. So it's testing factors 12, 11, 9, and 8, and that's the contact activation pathway, and also factors 10, 5, and prothrombin, which is the final common pathway. So there's definitely some overlap between what PT and PTT are testing. But then just for completeness, bleeding time is measured by using a specialized device. You make a cut in the patient's arm, a standard cut that's a standardized length and a standardized depth, and then you keep blotting the blood away, and you measure how long it takes for the bleeding to stop. It usually takes somewhere around 2 to 9 minutes. Now, bleeding time is primarily a function of platelet function. It's measuring platelet function. It's not really testing the coagulation cascade at all. And again, we're going to talk about the role of platelets in a separate video. But disorders of the coagulation cascade should not affect the bleeding time at all. Let's discuss coagulation disorders, or coagulopathies. Now, these are very important for step 1. Several students reported having lots of questions on bleeding disorders. And we've already touched on hemophilia. Hemophilia A is associated with factor 8 deficiency, and hemophilia B with factor 9 deficiency. So factor 8 and factor 9 are both part of the intrinsic pathway, the contact activation pathway. So hemophilia will increase the PTT, but not the PT or INR, just the PTT. Coagulation disorders don't just cause microhemorrhages, they cause macrohemorrhages. And when we talk about platelet disorders in another video, we'll see that platelet dysfunction tends to cause microhemorrhages, but coagulation disorders cause macrohemorrhages like hemarthrosis or bleeding into the joints, and maybe some easy bruising. And if these patients have trauma, they can have major hemorrhaging. The other coagulopathy I want to discuss is vitamin K deficiency. Vitamin K is a cofactor for the synthesis of several clotting factors, which you definitely need to know. Now, I'm sure you're wondering why on earth I'm dressed like this. It's not just because I want to play that funky music, white boy. It's to help you remember that the vitamin K-dependent clotting factors are factors 2, 7, 9, and 10, and also proteins C and S. And the mnemonic for this is the phrase, disco started in 1972. Now, that may not be historically accurate, but 1972 reminds you of the factors 10, 9, 7, and 2, and then the S and C in disco remind you of protein S and protein C. So patients with vitamin K deficiency will have decreased levels of all those factors. So PT and PTT will both be elevated. So when do you have vitamin K deficiency? Well, one possibility would be someone who isn't taking in enough vitamin K. Newborns might have vitamin K deficiency because we get a lot of our vitamin K from our gut bacteria. So our gut bacteria make vitamin K for us and then we absorb it. But newborns don't have any gut bacteria. They haven't been colonized yet. So it's pretty standard protocol to give a vitamin K injection to newborns to prevent vitamin K deficiency and to prevent coagulopathies. Patients on warfarin basically have a functional vitamin K deficiency. We're going to get to that in the next video. And one other scenario is end-stage liver disease. These patients aren't vitamin K deficient, but that diseased liver can't make coagulation factors, so it looks just like vitamin K deficiency clinically, at least in terms of the coagulation defect. But with advanced liver disease, you're also going to have jaundice and portal hypertension and all those other problems. So that's pretty much it for the pure coagulation disorders. There are a couple of mixed disorders that involve both the clotting factors and the platelets. We're going to cover those in the platelet videos. Now let's talk briefly about disorders not of impaired coagulation, but of increased coagulation, hypercoagulable states. These might cause people to have spontaneous DVTs or a cerebral vein thrombosis, or rarely a spontaneous PE with no preceding DVT. Maybe a spontaneous stroke, although venous thrombosis is much more common than arterial thrombosis with these. So let's start with factor V Leiden. Now think back to the coagulation cascade. We said that factor V was an accelerating factor that helps factor 10 convert prothrombin to thrombin. And we said that factor Va is inactivated by protein C. Well, there's a specific mutation in factor V called factor V Leiden. It was named after the city of Leiden in the Netherlands where it was first discovered. Anyway, this mutation accounts for 40 to 50% of all inherited hypercoagulable states. The factor V Leiden mutation makes factor Va resistant to inactivation by protein C, so that factor V stays active longer, which leads to more coagulation. This is also sometimes called activated protein C resistance. The next one is the prothrombin gene mutation, or more specifically, the prothrombin G20210A mutation. And this predisposes to thrombosis. It's a mutation of guanine to adenine, that's the G and the A, at the 20210 position of the prothrombin gene. Now, to remember the number, I remember that 20210 is almost the same as Beverly Hills 90210, except it's 20210. Kind of stupid, but the stupid stuff is sometimes easier to remember. So those are the two biggest ones. Now, the other two hypercoagulable states are much less common overall. Antithrombin deficiency means you're unable to inactivate thrombin, so you're going to make more clots. Antithrombin also inactivates a bunch of other factors. And you don't necessarily need to memorize these, but they're factors 7, 9, 10, 11, and 12. So these patients can sometimes be resistant to heparin, because remember, heparin accelerates the activity of antithrombin. So if you have reduced amounts of antithrombin, that heparin isn't going to do much. Or you may have to give a much bigger dose of heparin to get the same effect. And then there's protein C deficiency, which means that you're unable to inactivate factors 5 and 8. Or you can have a protein S deficiency. Protein S basically is a cofactor that helps protein C work. So if you're deficient in either protein C or protein S, you won't be able to shut off the coagulation cascade and you're going to form lots of clots. Now, studies show that lots of these people are walking around all the time with these hypercoagulable states without necessarily having any thrombosis. But if you have one of these mutations and then you have a second hit, so you start smoking, or you start taking an oral contraceptive, or you have a malignancy, or you have prolonged immobilization, or whatever, anything that increases the likelihood of thrombosis, then you can develop thrombosis. So if you have a patient that has a recurrent DVT or a DVT for no known reason, they may need to be evaluated for one of these hypercoagulable states. And any patient with a history of thrombosis who's found to have one of these hypercoagulable states is usually going to be treated with lifelong anticoagulation. All right, now let's pause the video, work through the end of session quiz, then we'll go over the answers together. First question, what coagulation factor is deficient in hemophilia A? Remember, A sounds like 8, so it's factor 8. The next one, what coagulation factor is deficient in hemophilia B? Remember, B9, so hemophilia B is factor 9. And the last question, what is the clinical consequence of a deficiency in either protein C or protein S? Remember, protein C and protein S are both anticoagulants. So if you're deficient in an anticoagulant, you'll become hypercoagulable. So the clinical consequence is hypercoagulability. All right, that's it for Heme 1. Next up, we're going to talk about anticoagulant drugs. I'll see you then.
It's time for another warm-up. Let's get going. Which glomerular disease should be suspected most in a patient with each of the following findings? So first we have immunofluorescence shows a granular pattern of immune complex deposition, and light microscopy shows diffuse capillary thickening. So that's going to be your membranous glomerulonephritis. Could also be diffuse proliferative glomerulonephritis. Next, we have immunofluorescence shows that same granular pattern of immune complex deposition, but this time the light microscopy shows hypercellular glomeruli. So this is acute post-streptococcal glomerulonephritis, and those are inflammatory cells in the glomeruli. Next, we have immunofluorescence shows a linear pattern of immune complex deposition. So these are the anti-GBM antibodies in Goodpasture syndrome. Next, we have EM shows subendothelial humps and tram track appearance. That's going to be your membranoproliferative glomerulonephritis. Next, we have nephritis, deafness, and cataracts. That's going to be your Alport syndrome. Next, we have crescent formation in the glomeruli. So this is going to be seen in the rapidly progressive glomerulonephritis, or also referred to as crescent glomerulonephritis. Next, we have segmental sclerosis and hyalinosis on light microscopy. This is going to be your focal segmental glomerulosclerosis. Next, we have anti-GBM antibodies on immunofluorescence. These are going to be seen on the Goodpasture syndrome again. Chemosteel-Wilson lesions are seen with diabetic nephropathy. Purpura on the back of arms and legs, abdominal pain, IgA nephropathy. That's going to be the Hinock-Scholin purpura. Spiking of the glomerular basement membrane due to electron-dense subepithelial deposits. That's going to be your membranous glomerulonephritis. All right, that brings us to the end of our warm-up. Let's get to that lecture now.
In this video, we're going to talk about anticoagulant drugs. Nope, nothing funny about that. Let's get right to it. Let's start with heparin. We said heparin is a cofactor for the activation of antithrombin, which inactivates thrombin and factor 10A. Now, antithrombin can work without heparin, but heparin makes it something like 1,000 times more active. So heparin supercharges antithrombin. And heparin has a very short half-life. Heparin can be used almost any time you need anticoagulation. Pulmonary embolism, acute stroke, acute coronary syndrome or MI, DVT, and it can be used during pregnancy if you need anticoagulation because it does not cross the placenta. Now, how do we measure the effectiveness of heparin? What lab do we monitor to make sure the blood is adequately anticoagulated or to make sure it isn't too anticoagulated? Well, we monitor the PTT. Now, for side effects, any of these anticoagulant drugs can lead to bleeding, obviously, so that can be a problem. Heparin can cause bone loss, decreased bone formation, and osteoporosis. There's also a phenomenon known as heparin-induced thrombocytopenia, or HIT. Now, if you have a patient who's on heparin and the platelet count starts to drop either suddenly or gradually, and then they eventually become thrombocytopenic, this is very, very suspicious for heparin-induced thrombocytopenia. Basically, the way it works is that heparin binds to platelet factor 4, and then you get autoantibodies to that complex. And this autoantibody complex can then go around and activate platelets so that the platelets aggregate, then they get removed from circulation and destroyed. Now, it doesn't happen all that often, and it doesn't happen to everybody. Less than 5% of patients on heparin will have this. But the result is that these patients have thrombocytopenia, but at the same time, they're actually in a hypercoagulable state. Now, that's kind of counterintuitive. You might think that if the platelets are low, they're going to be hypocoagulable. But remember, these platelets are being activated and they're aggregating. So these patients are forming platelet plugs and they're at risk for thrombosis. So what do you do for heparin-induced thrombocytopenia? Well, you need to stop the heparin right away. That's the first thing. But remember, you have the patient on heparin for a reason, so you still want them to be anticoagulated. So now you have to do something else because the patient's no longer anticoagulated when you stop the heparin. So that brings us to the direct thrombin inhibitors, which are used to anticoagulate patients with HIT, or anytime you would normally use heparin, but it's contraindicated for some reason. Now, there's one group of thrombin inhibitors, like drugs like lepirudin and bivalirudin and desirudin. These are all derivatives of a peptide called hirudin, which was originally found in the saliva of leeches. Now, leeches suck blood, right? So they need to be able to keep the blood flowing. So leeches actually secrete a little anticoagulant in their saliva. It's actually pretty cool, although I'm not sure what pharmaceutical genius was sitting around thinking, I need to come up with a new anticoagulant. I know, leech spit. But anyway, hirudin directly inhibits thrombin. It's doing the same thing as antithrombin. It acts actually at the same point in the coagulation cascade as heparin does, but it works through a totally different mechanism. So lepirudin, bivalirudin, and desirudin are all derivatives of hirudin. Now there are other direct thrombin inhibitors that aren't derivatives of hirudin, including argatroban, and there's a newer one called dabigatran. Now anyway, if you have a patient with heparin-induced thrombocytopenia, you need to stop the heparin, then you're going to need to start a different anticoagulant. And some of these direct thrombin inhibitors are approved for that use, for treating heparin-induced thrombocytopenia. Now you don't need to really worry about which of these direct thrombin inhibitors are approved for which indications, but just know if you have HIT, you're going to want to switch to a direct thrombin inhibitor. Additionally, you want to put them on warfarin because they're going to need to be anticoagulated for an extended period of time because of this, for at least a month. So heparin and a lot of these thrombin inhibitors are IV drugs. They're not really used for long-term anticoagulation, but warfarin is an oral drug, so it can be used as an outpatient. So you start your thrombin inhibitor, wait for the platelets to come back up, and then once the platelets get above 100, 150,000, you start warfarin, then you can stop the thrombin inhibitor. Then also there are some low molecular weight heparins, such as the drug enoxaparin, which you may know better under the brand name Lovenox. There's also dalteparin and several others. Now these are smaller than heparin. They have a lower molecular weight, and they act mainly by stimulating antithrombin to inactivate factor 10A rather than by inactivating thrombin. They have a longer half-life than regular heparin, and they're usually given as subcutaneous injections twice a day, or sometimes just once a day, depending on what you're trying to do. Are you trying to treat a DVT? Then you have to give it twice a day. If you're trying to prevent a DVT, which we call DVT prophylaxis, you can use enoxaparin just once a day. So the dosing is a lot easier with these. And also, you don't have to monitor them. The low molecular weight heparin dosing is weight-based, so it doesn't have to be monitored. With regular heparin, which we call unfractionated heparin, it's often given IV, and you have to check the PTT 6 hours after you started it, and then adjust the heparin dose, and check again in another 6 hours. So it's very high maintenance. With these low molecular weight heparins, not only do you only give it once or twice a day, but your dose is based on the patient's weight. So you calculate your dose, then you don't have to check any labs. But if for some reason you do want to monitor it, you don't use the PTT. Instead, you would check an anti-factor 10A activity. Now, one last thing about these low molecular weight heparins that's very important clinically is that they're not interchangeable. They have very different kinetics, very different dosing regimens, very different approved indications. I can't imagine you're going to be tested on that, but it will be important for you on the wards. And there's also a drug called fondaparinux that also works by activating antithrombin and inhibiting factor Xa. So it's kind of like the low molecular weight heparins, but it's technically not a heparin derivative. And then there's yet another group of drugs called the direct factor Xa inhibitors that I want to mention very briefly. These include drugs like rivaroxaban and apixaban, and there are several more of these drugs. But anticoagulants are a booming business. There's tons of these drugs coming out all the time. When I was in med school 15 years ago, there was heparin, there was warfarin, and they had just started developing the very first low molecular weight heparin. And that was it. That was all we had. Now we've got about 10 low molecular weight heparins, plus 2 or 3 entirely new classes of anticoagulants, and each one of those classes has half a dozen different drugs in the class. But anyway, rivaroxaban and apixaban are oral anticoagulants that work by inhibiting factor Xa, kind of like enoxaparin. They're sometimes used in AFib. They're also used to prevent post-op DVTs in patients who've had knee or hip replacement. And if you look at the names of these, you see the letters XA right in the middle, and that's going to help you remember that these are factor Xa inhibitors. The next drug to discuss is warfarin, or the brand name is Coumadin, which is a name you're going to hear a lot. So it's one brand name you definitely want to know, even though they're not going to use that name on your test. They'll say warfarin. But warfarin is definitely a high-yield drug, 4 stars. Warfarin inhibits an enzyme called epoxide reductase, which is responsible for recycling vitamin K. And vitamin K is used in the synthesis and gamma carboxylation of vitamin K-dependent clotting factors. So warfarin prevents your liver from being able to manufacture these specific clotting factors. Now, we've already talked about the vitamin K-dependent clotting factors being factors 2, 7, 9, and 10, and also protein C and protein S. So warfarin inhibits those factors, and that's going to affect the PT, or the prothrombin time. Now, we use warfarin for chronic anticoagulation for a wide variety of conditions. Atrial fibrillation is a big one because the blood becomes stagnant in the left atrium when the atrium isn't contracting normally, and those AFib patients are at an increased risk of embolic stroke. We also use warfarin for DVT prophylaxis or DVT treatment, and also PE treatment, although I always tell patients that the warfarin isn't really going to dissolve the clot that's already there. Your body's going to resorb that clot on its own over several weeks to months. We're just giving warfarin to prevent the clot from extending. And warfarin is contraindicated in pregnant women because it does cross the placenta and it's a teratogen. Specifically, warfarin can cause bone and cartilage problems in the epiphyses and possibly some nasal hypoplasia, incomplete development of the nose. So what anticoagulant is safe in pregnancy? Heparin, or one of the low molecular weight heparins. Now, heparin and warfarin are 2 of the most commonly used classic anticoagulants. Like I said, they've been around a long time. So let's take just a moment to review some basic differences between them. Heparin is an IV or subcutaneous drug. It's an injectable drug. Warfarin is an oral drug. So that's one reason we use warfarin chronically instead of using heparin. Heparin has that short half-life, so you usually have to give it continuously. And like I said, you can check the PTT a few hours after a dose change and see whether you achieved the desired effect. So it has this very rapid onset of action. Warfarin, on the other hand, has a long half-life and it has a very slow onset of action. It's really only affecting the synthesis of new clotting factors. It doesn't do anything to the clotting factors that are already out there in circulation. So you start warfarin, then you have to wait 2 or 3 days before you're going to see that INR start to change. And even then, it's going to take a good 5 days before that INR is stabilized. So getting a patient on an appropriate therapeutic dose of warfarin can take several days. And I said this in the previous video, but just to reiterate, when you first start warfarin, the first factors affected are actually protein C and protein S, especially protein C. So when you first start warfarin, the patient's going to become transiently hypercoagulable. And that can lead to some skin necrosis, and that's a bad thing. So when you start warfarin, the patient generally needs to be on either heparin or enoxaparin to counteract that transient hypercoagulability. And then once the INR is in the therapeutic range, which is usually an INR of 2 to 3, then you can stop the heparin or stop the enoxaparin and continue the warfarin by itself. The other difference between heparin and warfarin that I want to highlight is the treatment of an acute overdose. So the reversal agent for heparin overdose is protamine sulfate. So if somebody accidentally got too much heparin and you needed to reverse it quickly, you would give protamine sulfate. Now you have to use it very carefully because why are you putting the patient on heparin? To anticoagulate them. When you give protamine sulfate, it binds to the heparin and it reverses the anticoagulation, and that could lead to clotting, which is what you were trying to avoid in the first place. And then for overdose of warfarin, you give oral or IV vitamin K. Now we don't give subcutaneous vitamin K because it's not as effective. And actually, IV vitamin K doesn't work any faster than oral vitamin K does, and there's a small risk of anaphylaxis with the IV route. So I would recommend oral vitamin K. It always seems like IV is going to be faster than oral, but in this case it really isn't. The other thing about giving vitamin K is that it takes days to really do anything to reverse the effects of warfarin, right? You got to wait for your liver to start making those clotting factors again. But what if you have a patient who's bleeding to death right now and you need to reverse the warfarin quickly? Well, in addition to giving vitamin K, you can give prothrombin complex concentrate, or PCC, which is basically an infusion of the vitamin K-dependent coagulation factors. Now, if PCC isn't available, you could give fresh frozen plasma, but PCC is considered first line for active bleeding due to warfarin overdose. So for heparin overdose, you give protamine sulfate. For warfarin overdose, you can give vitamin K and PCC.
I don't always use warfarin, but when I do, I monitor the PT and INR. Stay anticoagulated, my friends.
Then finally, let's quickly cover the thrombolytics. Streptokinase, urokinase, TPA or alteplase. There's several of these different thrombolytic drugs too, and these are your clot-busting drugs. Why are they called clot-busting drugs? Well, these thrombolytic drugs activate plasmin. We talked about how plasminogen is converted to plasmin, and then plasmin lyses the fibrin clot. So plasmin degrades fibrin. These thrombolytic drugs activate plasmin, so they bust up the clots by breaking down fibrin. They're thrombolytics. They lyse thrombus. They lyse clots. Now, when do we use these? Well, we use them in early ST elevation MI, but only if you're somewhere out in the boonies and there's no cath lab. For the most part, acute ST elevation MIs are going to get angioplasty and stenting and open up that vessel. But if that's not available for whatever reason, you can give TPA, and that's going to lyse the thrombus and help reperfuse the heart. They also get used in treating an acute stroke, but again, very early on. When we talked about stroke, I mentioned that there are a whole bunch of very specific exclusion criteria. Relatively few patients who come in with an acute stroke are actually going to be candidates for TPA. Then for side effects, if you break up clots, you're more likely to bleed. So these are contraindicated in patients with active bleeding. And like I said, there are lots of exclusionary criteria before you give thrombolytics. So you pull the drug out and you go through this checklist of like 20 different things. They have this, they have that, they've been experiencing this. If any one of those things is present, like maybe they had surgery yesterday, you cannot give one of these drugs because the risk of complications outweighs the benefit of the drug. So these are contraindicated in patients with active bleeding, patients with any history of intracranial bleeding, recent surgery, any known bleeding disorder like maybe hemophilia, or severe hypertension. And then the reversal agent for these drugs is aminocaproic acid. Definitely know that. So that's it for the anticoagulant drugs. Now it's time for the end of session quiz. All right, first question. What lab test is used to monitor adequate anticoagulation in a patient taking heparin and in a patient taking warfarin? So for heparin, it's the PTT, the partial thromboplastin time, and then for warfarin, it's the PT, the prothrombin time, and with that, the INR. Next, what are the treatments for overdose of heparin and for warfarin? For heparin, you treat an overdose with protamine sulfate, then you treat warfarin overdoses with vitamin K and either PCC or fresh frozen plasma if there's active bleeding. And the last question, what's the treatment for heparin-induced thrombocytopenia? So the first thing, stop the heparin. And then you have to start a different anticoagulant like lepirudin or argatroban because these patients are now hypercoagulable due to all that platelet activation, so they need to be on a different anticoagulant. And we've also got a few rapid-fire facts for you. The preferred anticoagulation for immediate anticoagulation is either going to be heparin or maybe a low molecular weight heparin. Then the preferred anticoagulant for long-term anticoagulation is warfarin. And then the preferred anticoagulation during pregnancy is either heparin or a low molecular weight heparin, but definitely not warfarin. That's it for now. I'll see you next time.
It's time for another warm-up. Let's get going. Which genetic syndrome is caused by each of the following underlying mechanisms? So first we have absence of the HGPRTase, that's Lesch-Nyhan syndrome. Deficiency of aldolase B, that's going to be fructose intolerance. Deficiency of cystathionine synthase, that's going to be homocystinuria. Galactose-1-phosphate uridyl transferase deficiency, resulting in intellectual disability, hepatosplenomegaly, and cataracts, that's going to be galactosemia. Next, we have deficiency of tyrosinase, that's going to be albinism. Next question, what is Potter sequence? So this is where you have a bilateral renal agenesis because there is a malformation of the ureteric bud. That causes oligohydramnios because the fetus is not making urine, and that causes a lot of problems as well, like limb deformities, facial deformities, and pulmonary hypoplasia. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to discuss some basic concepts related to red blood cells. We've already talked about the physiology of hemoglobin and the oxygen carrying capacity of red cells, but now we're talking more about some terminology used to describe red cells and the various abnormal shapes that red cells can take on in various disease states. So the formal scientific sounding name for red cells is erythrocytes. They're anucleate, so they've lost their nucleus, and they're biconcave, so that they have a large surface area, which helps facilitate gas exchange. They're also very flexible, which is important because they have to be able to squeeze through those narrow capillaries. And the main molecule that's responsible for the biconcavity and the flexibility is a cytoskeletal protein called spectrin. So make sure you're familiar with that name. So anytime you lose that classic biconcave shape, like with sickle cell disease or with hereditary spherocytosis, the blood becomes more viscous, which can lead to sludging in the capillaries because the red blood cells are taking the wrong shape. Now, we've mentioned a few times already that red cells rely on glucose for their energy. Even in the fasting state, your red cells still need glucose. 90% of that glucose is anaerobically metabolized to lactate, and 10% is metabolized by the HMP shunt. And we mentioned that if you have a deficiency of pyruvate kinase, which is an enzyme in the glycolysis pathway, that's going to cause a problem getting energy to the red blood cells, and the red cells will hemolyze. We'll see that again when we talk about causes of hemolytic anemia. You should also know that the average lifespan of a normal, healthy, mature red cell is about 120 days. That's potentially testable. You also need to be familiar with the special vocabulary used to describe red cells. So if a pathologist looks at a peripheral smear and says there's anisocytosis, what does that mean? Anisocytosis means you have red cells of varying sizes. So iso means same. So anisocytosis means the cells are not all the same size, which is abnormal. Or the pathologist might report that there's poikilocytosis. Poikilocytosis means you have cells of varying shapes. We'll get to all those weird shapes in a second. If you have too many red cells, that might be called polycythemia, or it could be called erythrocytosis, two terms for the same thing. And the immature red cells are called reticulocytes. So when your bone marrow is busy churning out new blood cells, you're going to see more and more of those immature forms on the smear, and that's called reticulocytosis. But here's some good news. You don't really need to worry about remembering all the different stages of different red cell precursors. Let's talk about some more things that the lab might report on a peripheral blood smear. Various types of pathological red cells. So these are definitely high yield for you to know, and I'd be very surprised if you didn't have at least one question on one of these. Let's start with basophilic stippling. These are little purple basophilic dots all over the cell, which are thought to be clumps of denatured RNA within the red cell, or possibly ribosomes that clump together. The main disease state I want you to associate with basophilic stippling is lead poisoning. Now, there are other things that might cause basophilic stippling, such as thalassemias, anemia of chronic disease, and alcohol abuse, but I want you to remember lead poisoning as the main cause of basophilic stippling. There's a cell called an echinocyte, or a Burr cell, which has regular, uniform spikes all over its surface. So remember, regular spikes. So Burr cells are seen in uremia or renal failure, and they can also sometimes be seen in pyruvate kinase deficiency. And there's a similar looking cell called a spur cell, or the proper term for this is an acanthocyte. These cells are also spiky, but they are irregularly spiked. So the spacing of the spikes is irregular, and the size of the spikes is irregular. Some are big, some are little. Acanthocytes are seen in liver disease and A-beta lipoproteinemia. Spherocytes are red cells that lose their biconcave shape, so they become spherical. And the classic condition where you see these is called hereditary spherocytosis. Schistocytes are fragmented red blood cells, leftover pieces of red cells that have been chopped up. So imagine you have DIC or TTP-HUS, where you have pathologic intravascular clotting and a huge network of fibrin strands inside the blood vessels. And red cells are being forced through that fibrin mesh. So the cells get snagged on the fibrin, or a slice of the cell just gets sheared off. So again, a schistocyte is a fragmented red blood cell. Then the next one is target cells, which are really easy to identify because they look like a bullseye or a target. And they're much easier to identify than Walmart cells or JCPenney cells. There are a couple of different mnemonics to help you remember the diseases that cause target cells, but I like the mnemonic THAL, T-H-A-L, because that helps you remember that thalassemia is one of them, the H is for hemoglobin C disease, the A is for asplenia, and the L is for liver disease. So with liver disease you can see target cells, and then what other pathologic form did we just say you could see with liver disease? Acanthocytes, or spur cells. Now here you see sickle cells, which are sickle-shaped or crescent-shaped. And obviously we see these in sickle cell anemia. And then a Howell-Jolly body is the basophilic remnant of a nucleus in a red cell, which we see in patients with asplenia. no spleen. Maybe they had trauma to their spleen and it ruptured and they had to have it surgically removed. Or sometimes patients with immune thrombocytopenia will have their spleen removed surgically to treat the ITP. Patients with sickle cell disease will infarct their spleens over and over through the years until basically there's no functioning spleen tissue left. But any of these patients with asplenia for any reason could potentially have Howell-Jolly bodies in their red cells. A similar looking finding is called Heinz bodies. So Heinz bodies are these little clumps of denatured hemoglobin which shouldn't be there. And as these red cells pass through the spleen, the splenic macrophages just bite the Heinz bodies right out of the cell. And that leaves something called a bite cell. Now think back. When did we mention bite cells and Heinz bodies and oxidative damage to red cells before? G6PD deficiency, remember? Patients with G6PD deficiency are sensitive to certain drugs that cause oxidative damage, like sulfonamides and dapsone, and also favabeans. That's a classic one. Now, do you remember the mnemonic? It was spleen purges nasty inclusions from damaged cells, which stands for sulfonamides, primaquine, nitrofurantoin, isoniazid, favabeans, dapsone, and chloroquine. So make sure you know those. We talked about this back in biochemistry when we talked about the hexose monophosphate shunt. So patients with G6PD deficiency can't go through the HMP shunt, so they can't generate reduced glutathione, so their hemoglobin gets oxidized and it forms Heinz bodies. And then the splenic macrophages remove the Heinz bodies and that results in bite cells. And one other thing, it might be tricky to tell a Heinz body from a Howell-Jolly body, but a Howell-Jolly body is a remnant of the nucleus. So a red cell might have many Heinz bodies, but it can only have one Howell-Jolly body per cell. So for Heinz bodies, think about Heinz 57 steak sauce. 57 is a big number, so you can potentially have lots of Heinz bodies in a cell. There are teardrop cells, which are shaped like teardrops, and they're seen with myelofibrosis. You can also see elliptical-shaped red cells, which are called elliptocytes, and these are seen in something called hereditary elliptocytosis. Sometimes you may hear these called pencil cells or cigar cells. And finally, I want to discuss sideroblasts and ring sideroblasts for just a second because this is potentially confusing and it gets mixed up a lot. So first of all, what is a sideroblast? A sideroblast is a nucleated red cell precursor that has granules of iron in the mitochondria. And sideroblasts are found in the bone marrow of normal, healthy people. So sideroblasts are perfectly normal. They're not pathological. And again, they're found in the bone marrow, not in the peripheral blood. However, if you have a disorder that affects heme synthesis, the sideroblasts can't use all the iron that's stored in those iron granules. So they have too many granules, and the iron granules sort of surround and encircle the nucleus. So they form a ring around the nucleus. Now we call this a ringed sideroblast. So sideroblasts are normal, but ringed sideroblasts are abnormal. And where do you find these ringed sideroblasts? Again, they're found in the bone marrow. Not the peripheral blood, but the bone marrow. Now, patients with disorders of heme synthesis are going to be anemic, and when you do a bone marrow biopsy, you're going to see large numbers of these abnormal ringed sideroblasts. So these diseases are said to cause sideroblastic anemia. Now, lots of different things can cause sideroblastic anemia. Certain genetic conditions, certain drugs, chronic alcohol use, and myelodysplastic syndromes. So sideroblastic anemia isn't a diagnosis in and of itself. It's a sign of some other underlying disease. Now, you may sometimes see lead poisoning listed as a cause of sideroblastic anemia, but that's not really well documented. We're going to talk about lead poisoning in the next video. Now, before we move on, let's do a quick whiteboard review to help make sure you have all these terms really locked down. For this whiteboard review, we're going to match these terms on the left, written in blue, with the definitions written in green on the right. So the first term is an acanthocyte, and that's another name for a spur cell, those red cells with irregular spikes. And what diseases do we say we saw the acanthocytes or spur cells? In liver disease and in A-beta lipoproteinemia. Now the next one is degmacyte, and I'm kind of sneaking this one in because a degmacyte is another name for a bite cell. Next we have echinocyte, and echinocytes are those cells with the regular uniform spikes. We said the other name for those were the Burr cells. The next one is erythrocyte, which is just a normal name for a normal red cell. Then Heinz bodies. Heinz bodies are those oxidated hemoglobin bodies that are found in the red cells, precipitated out in the red cells in patients with G6PD deficiency. Then a Howell-Jolly body is the nuclear remnant that are found in red cells in patients with asplenia. Then a reticulocyte is a name for an immature red cell. A schistocyte is a fragmented red cell that we see in patients with DIC and other forms of microangiopathic hemolytic anemia. And then a spherocyte is obviously a spherical red blood cell. So good job with those. Next, I want to talk about a couple of topics related to blood transfusions. So first of all, there are several different types of blood products that you might be transfusing. The most common blood product to transfuse is packed red blood cells, or PRBCs. These are red blood cells that have been separated from the other donor blood components. So it's concentrated red blood cells, which we usually give to patients that have significant anemia, especially from acute blood loss, from trauma, or maybe a GI hemorrhage, or maybe from surgery. And you can kind of reason out why we would give red cells. Patients with anemia have decreased hemoglobin, so we want to increase the oxygen carrying capacity. We transfuse platelets for certain types of thrombocytopenia, especially if there's active bleeding due to thrombocytopenia, or if a thrombocytopenic patient needs to have surgery and you're worried about post-op bleeding. Or possibly you might give platelets to a patient whose platelet count is normal, but the platelets themselves are defective, so the patient can't stop bleeding. Sometimes we transfuse fresh frozen plasma, or FFP, which is plasma from which the red cells and other cellular components have been removed. So it's basically serum, the water and electrolyte portion of the blood, plus the plasma proteins and the clotting factors. Now, FFP is sometimes given to patients with a clotting factor deficiency, like in a patient with cirrhosis whose liver isn't making clotting factors, or in disorders like DIC, or thrombotic thrombocytopenic purpura, or TTP. Both of these are disorders in which there's widespread intravascular coagulation and all the clotting factors are being consumed. But the idea here is to give FFP to replace the coagulation factors that are missing. Now, there's a similar blood product that we give to patients with a warfarin overdose who are bleeding and who we need to rapidly reverse that anticoagulation. Remember what that blood product was? It's called prothrombin complex concentrate, or PCC, which is basically an infusion of the vitamin K-dependent coagulation factors, which are factors 10, 9, 7, and 2. Then one more blood product you might transfuse is called cryoprecipitate. This is similar to FFP or PCC, but you basically thaw the FFP and you collect just the clotting factors, especially fibrinogen and factor VIII, and also some von Willebrand factor. So you can use it for patients with DIC or TTP because these patients are consuming all their fibrinogen. So you can give cryoprecipitate just like you would FFP. Or you might give it to a patient with hemophilia A where you wanted to give factor VIII. But overall, we don't use cryoprecipitate much anymore. It's more common to give specific clotting factors that have been pooled from multiple donors. So if you have a patient with factor VIII deficiency, you just give pooled factor VIII rather than cryo. And just to mention briefly, the risks involved with giving transfusions include things like iron overload. So you have a patient who receives a ton of packed red cells. If they weren't iron deficient, they could end up with too much iron, and they can get hemochromatosis from that. They could develop some hypocalcemia because red cells are stored with sodium citrate to prevent coagulation of the blood. And when that citrate gets transfused, that citrate can bind to all the patient's calcium, and that can lead to hypocalcemia. The patient could develop hyperkalemia if the red cells have been sitting in storage long enough that some of the older red cells have started to lyse, and the intracellular potassium spills out into the transfused fluid. And there's a very small risk of infection because we screen blood donors for all sorts of infectious things like HIV and viral hepatitis and so on. And of course, there's a risk of transfusion reactions, which are discussed in the immunology videos. And speaking of transfusion reactions, make sure you review the blood types, or ABO blood groups. Now, you probably learned everything you need to know about ABO blood types back in high school biology. I don't really have much to add that you probably don't already know about that. So you can review those on your own if you need to. But two quick things I do want to point out. First of all, what happens if you transfuse an incompatible blood type? Well, you're going to get an antibody-mediated type 2 hypersensitivity, right? Circulating antibodies bind to the cellular antigens, and that leads to hemolysis, fever, possibly shock, kidney failure, and death. And then what's the number one cause of transfusion reactions? It's clerical error. Somebody goofed on the type and cross, or somebody mislabeled the blood, or it got delivered to the wrong floor or whatever. So you're going to see the nursing staff going through this huge checklist, checking the patient's ID bracelet, checking the labeling on the blood products, being extra cautious. Because these transfusion reactions can be really dangerous, but they're pretty much totally preventable. There's one disorder related to blood type incompatibility that you should know something about, which is erythroblastosis fetalis. And that's specifically due to Rh incompatibility. So take a look in the study guide. Erythroblastosis fetalis occurs due to maternal antibodies against fetal red cell antigens. typically antibodies to RHD. So Rh negative moms who don't have that RHD antigen on the surface of their red cells do not naturally have antibodies to RHD. It's only after mom is exposed to RHD antigens on the Rh positive baby's red cells that mom starts developing antibodies. So this exposure may occur during the first pregnancy with an Rh positive baby, but these antibodies don't cause problems during that first pregnancy. The antibodies only develop in a quantity abundant enough to cause problems in subsequent pregnancies. So if there's any trauma or something where the baby's blood comes into contact with the mother's blood, which could include delivery, so if the baby's blood comes into contact with mom's blood during that first pregnancy, mom's immune system becomes sensitized to the RHD antigens, and mom starts making anti-RHD antibodies. Then, on subsequent pregnancies, if the baby is Rh positive, the mom's anti-RHD IgG antibodies can cross the placenta and attack the fetus's red cells. So the clinical features of a neonate with erythroblastosis fetalis include anemia due to hemolysis of those fetal red cells, and then those cells hemolyze, hemoglobin is going to be released, and that hemoglobin is converted into bilirubin, and the bilirubin causes jaundice and possibly kernicterus in the neonate. The fetus can also develop hydrops fetalis, which is a generalized fetal edema. And be aware that erythroblastosis fetalis is life-threatening, and it can cause intrauterine death. So what do we do to prevent all this? Well, we give Rh-negative moms anti-RHD immunoglobulin at 28 weeks, or whenever there's any type of trauma, like a motor vehicle accident, or anytime there's an abortion or miscarriage, and also within 3 days of delivery. Basically, anytime the mom might be exposed to the fetal red blood cells, you're going to give anti-RHD immunoglobulin, which is IgG, to sort of hide those fetal red blood cells so that the mom's immune system never sees them. Once the mom's immune system starts seeing those fetal RHD antigens, she's going to develop an immune response to them. So we hide the RHD positive fetal red cells by giving anti-RHD immunoglobulin so that mom never develops that immune response. So again, the scenarios where the mom's immune system is likely to see those red blood cells would be after 28 weeks, because you're more likely to deliver after 28 weeks, and at any traumatic event where you might have mixing of blood crossing the placenta, and also within the first 3 days of delivery. So now it's time for the end of session quiz. So pause the video and answer those questions, then restart the video, and we'll go over the answers together. First question, what allows red cells to change shape as they pass through vessels? That's the protein spectrin. Next, what name is given to immature erythrocytes in circulation? We call them reticulocytes. Next one, what pathologic form of red cell would you see in the following diseases? So with lead poisoning, you see red cells with basophilic stippling. With G6PD deficiency, you might see bite cells and also Heinz bodies within the red cells. With DIC, you're going to see schistocytes. With A-beta lipoproteinemia, you're going to see acanthocytes, which are also called spur cells. And with asplenia, you might see Howell-Jolly bodies and also possibly target cells. And that's it for now. I'll see you next time.
It's time for another warm-up. Let's get going. First question here, what is the difference between kwashiorkor and marasmus? So kwashiorkor is protein malnutrition, so you see skin lesions, edema, and liver malfunction. Think about maybe a small child with that very swollen belly that sometimes you see on TV. Now with marasmus, instead of just protein malnutrition, you have complete nutrient deficiency and energy malnutrition. So you don't see the swollen belly. Instead, you see tissue and muscle wasting, loss of subcutaneous fat. There may be some edema, but it isn't as prominent as with kwashiorkor. Next, which vitamins should vegetarians take to supplement their diet? So the main one is probably going to be vitamin B12. All right, guys, that brings us to the end of the warm-up. Let's get to that lecture.
In this video, we're going to talk about erythropoiesis, or the process of making red blood cells, and some things that can go wrong with that process. Now, I've already said you don't need to worry about memorizing all the different cell types that go from myeloid progenitor to pronormoblast to polychromatophilic normoblast and so on. Too much detail. But let's talk about the details that you do need to know. The first primitive blood cell progenitors appear in the yolk sac at about 3 weeks. And then the true hematopoietic stem cells come from the mesoderm, from near the mesonephros region of the embryo. And then after a couple of weeks, these stem cells migrate to the liver. Now, there's a helpful mnemonic. Young liver synthesizes blood. I love mnemonics where the phrase actually links to what you're trying to remember. So, young liver synthesizes blood. So hematopoiesis starts off in the yolk sac, from week 3 until about week 8. And then the liver and the spleen take over, though the liver is the most important site of hematopoiesis pretty much throughout fetal development. And then beginning around 28 weeks, the primary site of hematopoiesis is the bone marrow. And then make note which bones we're talking about. In infancy and childhood, the marrow of basically the entire skeleton is hematopoietically active. It tends to be things like the sternum, the pelvis, the ribs, the cranial bones, the vertebrae, and also the long bones of the leg, which are the tibia and the femur. So think about those long bones and flat bones. And then around late adolescence or early adulthood, those long bones become quiescent, and you're basically left with the axial skeleton throughout the rest of adulthood. So again, vertebrae, sternum, ribs, and pelvis. And then remember that there are some structural differences between adult and fetal hemoglobin. A molecule of hemoglobin is made of 4 different globin chains. In adults, it's 2 alpha chains and 2 beta chains. Now, the alpha globin gene cluster is found on chromosome 16, and the beta globin gene cluster is found on chromosome 11. So that's adult hemoglobin, hemoglobin A. Fetal hemoglobin is made of 2 alpha chains and 2 gamma chains. Now, what's the difference? Well, those gamma chains have a lower affinity for 2,3-DPG, or 2,3-diphosphoglycerate. And because of that, fetal hemoglobin has a lower affinity for 2,3-DPG and a higher affinity for oxygen than adult hemoglobin does. So when maternal blood arrives at the placenta and there's a lot of 2,3-DPG around, the maternal hemoglobin lets go of oxygen and binds to 2,3-DPG. And that's how we get that transfer of oxygen from mom to fetus across the placenta. So let's look at the study guide and talk a little bit more about different kinds of hemoglobin that you can see with different globin chains. There are several normal hemoglobin variants that you need to be familiar with, and also some pathological variants. So we said normal adult hemoglobin is made of 2 alpha chains and 2 beta chains, and that's called hemoglobin A. A for adult. Hemoglobin A makes up about 97% of hemoglobin in a normal, healthy individual. Now, hemoglobin A2 is 2 alpha chains and 2 delta chains, and that's about 2 to 3% of hemoglobin in normal adults. Then hemoglobin A1C, we covered that with diabetes. It's just normal hemoglobin that's been, normal hemoglobin A anyway, that's been non-enzymatically glycosylated because the blood glucose was so elevated. So it's hemoglobin A1C, is a subtype of hemoglobin A. Then hemoglobin F is that fetal hemoglobin, 2 alphas and 2 gamma chains. So gamma chains replace the beta chains in hemoglobin A. Or another way to look at this is that as the fetus transitions from fetal hemoglobin to adult hemoglobin during the last few weeks of pregnancy and the first few weeks of postnatal life, the gamma globins are replaced with beta globins. Hemoglobin Gower is present even earlier in development during the embryonic period. So hemoglobin Gower is 2 zeta chains and 2 epsilon chains. Hemoglobin S is what we see in sickle cell disease, where there's a single amino acid substitution in the beta chain from glutamic acid to valine. And hemoglobin C is a similar variant that's also often seen in sickle cell populations, which is a substitution from glutamic acid to lysine. Then hemoglobin Bart's and hemoglobin H are where you don't have any alpha chains at all. We're going to cover those in detail in the next video with the thalassemias. The other part of hemoglobin, besides the globin chains, is the heme molecules. And those red cell precursors have to be able to make heme correctly. So let's talk about heme synthesis and then some diseases of heme synthesis like porphyria. And there are a few main points to know here. Number 1, you've got to know that the rate-limiting enzyme of heme synthesis is aminolevulinic acid synthase, or ALA synthase. So you start with glycine and succinyl-CoA, and you make aminolevulinic acid, or ALA, and you use this enzyme, aminolevulinic acid synthase. So definitely know that. And then vitamin B6 is required for that step. Number 2, you don't need to know every enzyme and every step in this heme synthesis pathway, but you should know which steps are defective in porphyria and also in lead poisoning. Now, there are several different types of porphyria. We're just going to focus on 2 of them, acute intermittent porphyria and porphyria cutanea tarda. Now, you need to be familiar with both of these because they're caused by enzyme defects at 2 different steps. So let's talk about acute intermittent porphyria first. Acute intermittent porphyria is caused by a deficiency of uroporphyrinogen 1 synthase, which is also known as porphobilinogen deaminase. But the main thing with acute intermittent porphyria is to be able to recognize the presentation of the disease. So it's going to present with abdominal pain, which is a neuropathic pain. Those intermediate heme precursors are thought to be neurotoxic. Patients are going to have port wine urine. It's a very dark or reddish urine because of excess heme precursors that build up in the blood and then spill into the urine. And then polyneuropathy, again, this is a neurological dysfunction taking place, psychological disturbances. So again, those heme precursors are neurotoxic and that can lead to some psychological problems. And then the last point about the presentation is that this is precipitated by drugs. So things like barbiturates, seizure drugs, rifampin, and metoclopramide can trigger this. Now we treat acute intermittent porphyria by giving glucose and heme, which inhibit the ALA synthase, that rate-limiting enzyme. So the presence of heme will down-regulate the ALA synthase enzyme so you don't get buildup of those neurotoxic intermediate products. So definitely be able to recognize that. You can also use the acute in acute intermittent porphyria to think of the acute abdomen and acute psychosis. So that's going to help you remember what this disease looks like. The other type of porphyria you need to know is porphyria cutanea tarda, which is primarily a cutaneous problem, a skin problem. You can probably guess that from the name. But this is the most common form of porphyria. It causes blistering of the skin and photosensitivity, so these patients blister when they go out in the sun. They can also get tea-colored urine. They can have hypertrichosis or excessive hair growth. They can have facial hyperpigmentation, and it's associated with hepatitis C and also with alcoholism. Even without hepatitis C or alcoholism, this is nearly always associated with elevations of LFTs like AST and ALT. So it may help to think of porphyria cutanea tarda patients as being a little bit like werewolves. They have hypertrichosis and they're active at night because of the photosensitivity. And then finally, with porphyria cutanea tarda, the heme synthesis enzyme that's deficient is called uroporphyrinogen decarboxylase. So make sure you know those enzymes. Porphobilinogen deaminase is deficient in acute intermittent porphyria, and then the enzyme uroporphyrinogen decarboxylase is deficient in porphyria cutanea tarda. Let's also look at how lead poisoning affects the heme synthesis pathway. Lead poisoning actually affects the pathway in two places. It affects ALA dehydratase, and it affects an enzyme called ferrochelatase, which is the final step. And while you're looking at the pathway, make note that inhibition of this ferrochelatase means that the red cells are going to have increased levels of protoporphyrin. Now, lead poisoning causes microcytic anemia, plus neurological manifestations, and a bunch of other problems we're going to go through in just a moment. Now, children will classically get lead poisoning from exposure to lead paint, either from old lead-based paint made before 1978 when they stopped putting lead in paint, and then it turns to flakes and it peels and it turns to dust. Or they might be exposed to it from lead in construction sites that gets into the soil and then gets tracked into the house. And that lead dust, whether from paint or from the soil, gets inhaled or gets ingested, and then these children develop neurological problems and mental deterioration. Now, adults can be exposed to lead the same way, but more typically adults with lead poisoning have some environmental exposure to lead, like they work at a factory where lead is used in manufacturing. And in adults, lead poisoning will typically cause headache, memory loss, and demyelination. So again, neurological problems. So what specific neurological problems are we talking about? Well, these patients, both adults and kids, can have sort of a global encephalopathy with memory loss and delirium, and mental deterioration like learning disabilities. They can also have peripheral nerve manifestations, specifically foot drop or wrist drop. I mentioned that lead poisoning will cause microcytic anemia. We're going to talk about anemia in the next couple of videos, but microcytic anemia means that the red cells are smaller than normal. And the red cells have that basophilic stippling, which are little basophilic clumps of denatured RNA within the red cell, or possibly ribosomes that clump together. And even though a lot of references will list lead poisoning as a cause of sideroblastic anemia with a ringed sideroblast, that's really not a well-documented finding. So yes, basophilic stippling with lead poisoning, but probably no sideroblastic anemia. Lead poisoning can cause lead lines on the gingivae, these dark bluish-black lines on the gums just above the teeth. They're sometimes called Burton's lines. You can also see lead lines on the x-rays of the long bones in growing children along the metaphyses. So where the bones are growing, you see this hyperlucent line. Lead poisoning can also cause colicky abdominal pain, and it can lead to renal failure in adults. So make sure you can recognize those manifestations of lead poisoning. We're going to review them again in just a second. Then finally, how do we treat lead poisoning? Well, there's a lot of discrepancy among textbooks about the best regimen for treating lead poisoning. If you need to give something to chelate the lead, you can use either EDTA or Succimer in either kids or adults. But if you need lead chelation for children with severe toxicity and very high lead levels, you can give dimercaprol plus Succimer. All right, let's go back and look at porphyria and lead poisoning in a whiteboard review. All right, let's take our little Dr. Lewis voodoo doll and we'll review the features of lead poisoning. So first of all, you have CNS toxicity, encephalopathy, memory loss, delirium. With that, you can also have headaches. You can see foot drop and wrist drop. You can have those lead lines on the gingivae. If you were a child, you can see lead lines on the bones on the x-ray. Patients can have renal failure. You can have abdominal colic. And they can have microcytic anemia with basophilic stippling. And while we're here, let's draw the findings of a patient with porphyria cutanea tarda. So these patients have facial hyperpigmentation, they have hypertrichosis, Dr. Lewis will love that. They can get photosensitivity and blistering, especially on the hands. This is associated with hepatitis C, so there's his liver, and maybe he's got a little jaundice. It's associated with elevated AST and ALT. And we also mentioned tea-colored urine. One last topic before we wrap it up, and that's polycythemia. Now, we said polycythemia was just another name for erythrocytosis, and that just means too many red cells. And there are lots of different things that can cause erythrocytosis. So there's polycythemia vera, which is a monoclonal proliferation of red cells, and it's a benign red cell neoplasm. We're going to cover that with the other myeloproliferative disorders in another video. Chronic hypoxia will cause erythrocytosis because you need to increase oxygen carrying capacity. So your kidneys recognize the low oxygen saturation and they start producing more of the hormone erythropoietin. And that stimulates the bone marrow to produce more red cells. So you might see this with pulmonary disease like COPD, or with obstructive sleep apnea, or cyanotic heart disease, or in people who live at high altitudes. You can also have polycythemia from inappropriate elevations of erythropoietin, something like an erythropoietin-producing tumor, and that's going to lead to polycythemia. Now, there are 4 tumors that classically do this. A year or two ago, a student sent us this terrific mnemonic, potentially really high hematocrit. So the P in potentially is for pheochromocytoma, R is for renal cell carcinoma, which is pretty easy to remember because the kidneys are supposed to be making erythropoietin. They're just doing it out of control now. Then the H in high is for hepatocellular carcinoma, and the 4th one is hemangioblastoma, which is a vascular CNS tumor. And it may also be worth knowing that about 60% of trisomy 21 babies have polycythemia at birth. So one way to think about all these causes of erythrocytosis is to think about whether this is a relative polycythemia or an absolute polycythemia. So relative polycythemia just means that the plasma volume is reduced so that the red cell count is increased relative to the plasma volume. So the absolute number of red cells is normal, but the plasma volume is contracted, so you have more red cells per unit of blood volume. Absolute polycythemia means that the plasma volume is normal, and you actually have too many red cells. And you can also break it down by whether this is an appropriate increase in red cell mass, like with hypoxia, as we just mentioned, or whether it's an inappropriate increase in red cell mass because of ectopic erythropoietin production. And then with polycythemia vera, again, this is due to neoplastic transformation of a red cell precursor, not due to excess erythropoietin. All right, let's move on to the end of session quiz. First question, where does fetal erythropoiesis take place? So the mnemonic was young liver synthesizes blood. So it starts in the yolk sac, then it moves to the liver and the spleen, and again, the liver is the major site of hematopoiesis before birth. Then around 18 to 20 weeks, the bone marrow starts producing red cells, and that gradually ramps up through the second half of pregnancy and also after birth. And then in adults, which bones does the erythropoiesis take place in? Well, it's basically in the axial skeleton, the vertebrae, the ribs, and the pelvis. Next, what are some of the different causes of polycythemia? Elevated erythropoietin, and again, that can be due to one of 4 neoplasms, pheochromocytoma, renal cell carcinoma, hepatocellular carcinoma, and hemangioblastoma. Remember, we had a mnemonic for those. Chronic hypoxia because of pulmonary disease like COPD, and that's also because of increased erythropoietin. And polycythemia vera can cause polycythemia, but here the erythropoietin level is low. And finally, we said that about 60% of trisomy 21 patients have polycythemia at birth. And the last question, what are the hematologic and non-hematologic findings in a patient with lead poisoning? So the hematologic findings include microcytic anemia, basophilic stippling, and then the non-hematologic findings include encephalopathy, memory loss, headaches, foot drop and wrist drop, those lead lines in the gingivae, lead lines on the bones in children, abdominal colic, and renal failure. That's it for now. I'll see you next time.
It's time for another warm-up review. Let's get going. How does hexokinase differ from glucokinase? Well, first of all, the location is different. Hexokinase is found everywhere, while glucokinase is only found in the liver and the beta cells of the pancreas. Now, insulin does not induce hexokinase, but it does induce glucokinase. And then hexokinase has a low Km and a low Vmax, but glucokinase is just the opposite. It has a high Km, a high Vmax. Next, which substrate and cofactor are required for the generation of GABA? Now, the amino acid glutamate is essential for the production of GABA and glutathione, an important antioxidant as well. Now, to answer the question, the substrate is glutamate, and the cofactor, though, is vitamin B6. Next, what medication inhibits alcohol dehydrogenase? And then what medications inhibit acetaldehyde dehydrogenase? Well, fomepizole inhibits alcohol dehydrogenase, and disulfiram is going to inhibit the acetaldehyde dehydrogenase. All right, that's it for the warm-up. Let's get to that video.
Over the course of the next few videos, we're going to review various types of anemia. Now, anemia is a huge topic, and it's very high yield. Though again, you're likely to get softball kinds of questions about classic presentations. But this is also a very important clinical concept to be able to think logically and systematically about what might be causing your patient's anemia. One very common way to think about anemia is to start by dividing up the causes of anemia based on the size of the red cells. Are they too small, which we call microcytic? Are they too large, which we call macrocytic? Or are they just right, which means they're normal size or normocytic? So we're going to review microcytic anemias in this video, and we'll review macrocytic anemia and normocytic anemias in the later videos. So what number on the CBC is going to tell you how big the red cells are? That's the MCV, or the mean corpuscular volume. So usually the first thing your attending is going to want to know when you start talking about anemia is, what's the MCV? You're going to see lots of different complicated diagnostic algorithms for what test to order next and so on, but for your exam, you just need to be able to lump the different types of anemia into microcytic and macrocytic and normocytic, and then split your normocytic anemias into hemolytic or non-hemolytic. So let's start with microcytic anemias. By far the most common cause of microcytic anemia is iron deficiency anemia, maybe from poor iron intake, or more commonly in the U.S., the land of iron supplements and red meat and iron-fortified breakfast cereals, more commonly we see blood loss causing iron deficiency anemia. It could be normal physiologic blood loss, like menstruation, or it could be abnormal blood loss, often GI blood loss, maybe from a colon cancer or a peptic ulcer or something like that, where you have chronic occult blood loss. Now, if on your test they give you a patient over the age of 50 with iron deficiency anemia and no easily identifiable cause, you need to rule out colon cancer. That patient needs a colonoscopy. You can also potentially see iron deficiency anemia due to increased iron demand, such as in pregnancy. So with pregnancy, you might see an iron deficiency anemia, but there's also something called physiologic anemia of pregnancy, where the plasma volume is increasing at a greater rate than the red cell mass is increasing. So the red cells are kind of diluted out, and there's relative anemia. Now with iron deficiency, the red cells are microcytic, which means they're small, and they're hypochromic, which means they're pale. You might also see something called Plummer-Vinson syndrome, which is a triad of iron deficiency anemia, esophageal webs, and dysphagia. This is one of those things you're more likely to see on a test than you are in real life. This may also be associated with atrophic glossitis. There are lots of nutritional causes of glossitis, especially B vitamin deficiencies, but you definitely need to remember that iron deficiency can also do it. The next couple of microcytic anemias are the thalassemias, starting with alpha thalassemia. So thalassemia is caused by a defect in globin synthesis. So remember, hemoglobin is made of 4 globin proteins. In the last video we talked about lead poisoning and porphyria as defects in heme synthesis, but thalassemia is a defect in globin synthesis. And again, normal hemoglobin A is made of 2 alpha globins and 2 beta globins. Now, alpha thalassemia occurs when you have a defect in alpha globin. Either your alpha globins are defective or you just don't make enough of them. And there are different degrees of alpha thalassemia which are related to the genetics. So normally you have 2 alpha globin alleles on chromosome 16, and you get 1 copy of chromosome 16 from mom and 1 copy from dad. So that's a total of 4 alpha globin alleles. Now, if you have a deletion or mutation in one of those alleles, that's pretty mild. And the other alpha alleles can still make plenty of alpha globin, so you have plenty of hemoglobin and no anemia. Now, if you have two mutated alleles, that's still pretty mild, and we call that alpha-thal trait or alpha-thal minor. And in general, that's not associated with any anemia either. But when you mutate three of those alleles and you're just left with one normal alpha gene, that's called hemoglobin H disease. So here you're making a ton of beta globin and very little alpha globin. So those beta globins start to pair up with one another so that a substantial amount of the hemoglobin is made up of 4 beta globins, and that's called hemoglobin H. Then, if you're deficient in all 4 alleles, that's incompatible with life. You don't ever get to the stage where you're making beta globin because as a fetus, you make all gamma globins instead of beta globins. So instead of hemoglobin H, the fetus has hemoglobin Bart's, which is made up of 4 gamma globins, that other component of fetal hemoglobin. And that hemoglobin Bart's is going to cause generalized fetal edema, which we call hydrops fetalis, and then death. So mostly, if you see alpha thalassemia at all, you're going to see alpha-thal trait with minimal anemia. It's more prevalent among Africans and Asians. Remember, alpha, A, Africans and Asians. Then the other type of thalassemia is beta thalassemia, which is still a defect in globin synthesis, but with beta thal, we're talking about a defect in the beta globin gene. And beta thal is seen in Mediterranean populations, so make sure to make that distinction. Alpha thal in African and Asian populations, beta thal in Mediterranean populations. So instead of 4 alleles like with alpha globin, you just have 2 genes for beta globin. But again, you could have a mutation that makes abnormal beta globin, or you could have a mutation that makes no beta globin whatsoever. So beta thal minor is where you have decreased amounts of beta globin. You have minimal anemia and increased hemoglobin A2 because hemoglobin A2 is made up of alpha globin and delta globin. You don't need beta globin to make hemoglobin A2. And then beta thal major is where you have no beta globins whatsoever. So you have severe anemia requiring blood transfusion, and that can lead to hemochromatosis with repeated transfusions. Now, how would you counteract that hemochromatosis? You're not going to do phlebotomy, right? That's kind of counterproductive to remove the red cells you just put in. So instead, you're going to use an iron chelating drug like deferoxamine. In fact, in a patient with microcytic anemia, you always want to make sure to check iron studies and confirm the diagnosis of iron deficiency before you start iron supplements. Because if you miss the diagnosis of beta thal minor, you can actually cause iron overload. So you need to check the iron studies, and you may need to check a hemoglobin electrophoresis and make sure they don't have high hemoglobin A2, because again, that would suggest beta thal minor. On the peripheral smear of beta thalassemia, you can see target cells. Again, the mnemonic for target cells is thal, thalassemia, hemoglobin C disease, asplenia, and liver disease. So all of those things can cause target cells. And with beta thal major, your bone marrow is all ramped up trying to make lots of hemoglobin, so you're going to see marrow hyperplasia. And that hyperplasia in the marrow of the skull creates this hair-on-end appearance of the skull X-ray. So we're going to see this in sickle cell disease as well. Sometimes it's called a crew cut appearance, same thing. The skeletal deformities in beta thal major also result in chipmunk facies. And in both thal major and thal minor, you have increased hemoglobin F, which just makes sense. If you have no beta chains, how else are you going to make hemoglobin? Well, you're going to use hemoglobin F, which is 2 alpha globins, which you have plenty of, and 2 gamma globins. It can also get very complicated if you are heterozygous for a beta globin mutation and for a hemoglobin S mutation, which causes sickle cell disease. That's going to cause mild to moderate sickle cell disease, depending on how much beta globin is actually being produced. Another cause of microcytic hypochromic anemia is lead poisoning. So we've already talked about lead poisoning as a cause of defective heme synthesis, and you can see basophilic stippling on the red cells. We talked about all the non-hematologic features of lead poisoning, especially those neurological manifestations and the lead lines on the gums and in the bones. I'm not going to go through all that again right now. But remember that the 2 heme synthesis enzymes that are affected by lead poisoning are ferrochelatase and ALA dehydratase. And we talked about how lead poisoning probably doesn't cause sideroblastic anemia. Remember, sideroblastic anemia is a result of defective heme synthesis, and you see those ringed sideroblasts in the bone marrow. And we mentioned that lots of different things can cause sideroblastic anemia. There's a hereditary form. You can also see sideroblastic anemia from chronic alcohol use or from certain drugs like various seizure drugs and isoniazid and chloramphenicol. And with sideroblastic anemia, you might see elevated serum iron levels and elevated ferritin because that iron isn't being used to make heme, so it's just kind of piling up. And we can often treat sideroblastic anemia with B6 supplementation. There's also a condition called anemia of chronic disease, which is caused by defective iron utilization and defective iron mobilization. We're going to see this in patients with chronic inflammatory diseases, especially things like rheumatoid arthritis, chronic infections, sometimes with malignancy. Sometimes it's called anemia of chronic inflammation. So you have this chronic inflammation that interferes with your body's ability to use iron. So the iron is basically trapped in macrophages, and the ferritin is normal or high, but the serum iron is low. This will often start out as a normocytic anemia, but if it's allowed to go on long enough, the red cells will start to become microcytic and hypochromic. So we're going to come back and talk about anemia of chronic disease again with the normocytic anemias, but again, it's not at all uncommon for anemia of chronic disease to cause a microcytic anemia. If iron deficiency anemia is the most common type of microcytic anemia, the first thing you're going to do when evaluating a patient with microcytic anemia is check the iron studies. So let's talk about how we use those lab results to help make the diagnosis. In the first two rows, we have iron deficiency anemia and anemia of chronic disease. And in both of these, the serum iron level will be low. The next column is TIBC, or total iron binding capacity. So this is a measure of how much transferrin is in the blood. Transferrin is a protein that transports iron in the blood. So anything that elevates transferrin is going to elevate TIBC. So transferrin is elevated in iron deficiency, but it's low in anemia of chronic disease. If you're iron deficient, your body is desperate to transport iron from storage to the bone marrow where it can be used. So your body's going to make lots of transferrin, and TIBC will be elevated. But in chronic disease, even though serum iron is low, that's not the main problem. So transferrin will be low. Then the next column is ferritin. So ferritin is a storage form of iron found inside of cells. So in iron deficiency, you've used up all the stored iron, so ferritin is going to be low. But in anemia of chronic disease, ferritin will generally be normal or elevated, but definitely not low. Remember, ferritin is an acute phase reactant. It's usually going to be elevated with any type of inflammatory process, so infections, cancer. So ferritin can be elevated for a lot of different reasons. One of those reasons is anemia of chronic disease. Then the far right column is percent transferrin saturation. So that's the ratio of serum iron to TIBC. It kind of tells you how much of the transferrin, that iron transport protein, is saturated with iron. And this value will generally be calculated for you when you order iron studies. In iron deficiency, the transferrin saturation is going to be markedly decreased because you've got a lot of transferrin out there, but you don't have much iron. So the percent saturation is going to be very, very low, usually less than 12%. For anemia of chronic disease, it's generally going to be in the normal range. Now, the normal range for transferrin saturation is anywhere from about 12 up to 45 or 50, so it's a very broad normal range. But generally, in anemia of chronic disease, you're going to have a transferrin saturation greater than 18%. Now, what do these iron studies look like in hemochromatosis? Well, hemochromatosis is where you have a lot of iron stored up. You have too much iron in the body. So serum iron will be elevated. TIBC and transferrin will be low because the transferrin is basically saturated. There's too much iron, so your body's not making more transferrin. Ferritin will be elevated. If you have normal ferritin, you can pretty much rule out hemochromatosis. Now, if you have elevated ferritin, it doesn't prove you have hemochromatosis. We said ferritin can be elevated for a lot of different reasons. So elevated ferritin doesn't prove there's hemochromatosis, but normal ferritin pretty much rules out hemochromatosis. And then in hemochromatosis, the percent transferrin saturation is going to be very high. Again, you have lots of iron, all the transferrin is saturated, so transferrin saturation is very high. Then what about sideroblastic anemia? Remember, sideroblastic anemia is due to impaired heme synthesis. So you should be able to reason out what it's going to do to these iron numbers. Iron and ferritin are both elevated because your body's not using iron to make heme, so you've got a lot of extra iron lying around. And whenever there's too much iron, the transferrin and TIBC are decreased. And since iron is elevated and there's lots of iron bound to transferrin in the serum, the transferrin saturation is going to be normal or elevated. And the overall transferrin or TIBC is going to be decreased. So the iron studies in sideroblastic anemia look a lot like the iron studies in hemochromatosis. The difference is that with hemochromatosis, there's no anemia, just too much iron. Now it's time for the end of session quiz. So I want you to pause the video, go through those questions, and then we'll go over the answers together. First question, what test can be used to diagnose beta thalassemia minor? We're going to do a hemoglobin electrophoresis to look for higher than normal levels of hemoglobin A2. Next, a patient is found to have microcytic hyperchromic anemia. What lab findings allow you to distinguish iron deficiency anemia from anemia of chronic disease? Well, in both of these, serum iron will be decreased. But in a patient with iron deficiency, they're going to have increased TIBC, decreased ferritin, and transferrin saturation will be low, less than 12%. Now, a patient with anemia of chronic disease will have decreased TIBC, ferritin will be normal or elevated, and transferrin saturation will be normal, greater than 18%. And the last question, what should you rule out in a man over 50 with new onset iron deficiency anemia? You need to rule out colon cancer. Now, really, you need to rule out colon cancer in both men and women, but colon cancer is more prevalent in men than in women. We also have some rapid-fire facts. The causes of hypochromic microcytic anemia mainly include iron deficiency, thalassemia, and lead poisoning, and sometimes anemia of chronic disease. Skull X-ray shows a hair-on-end appearance that would indicate marrow hyperplasia, typically from either beta thalassemia or sickle cell disease. And then basophilic stippling of red cells is typically seen with lead poisoning. That's it for now. I'll see you next time.
It's time for the 3-question warm-up for Heme 6. Let's get going. What is the rate-limiting enzyme of beta oxidation of fatty acids? So the answer is carnitine acyltransferase 1. Next question. What cofactors are required for the function of pyruvate dehydrogenase? And then what other enzyme requires the same cofactors? So first one that we need to know here is that mnemonic that we gave you. It's that tender, loving care for no one, which stands for thymine pyrophosphate, lipoic acid, coenzyme A, FAD, and NAD. And then what other enzymes require the same cofactors? That's going to be alpha ketoglutarate dehydrogenase. Next question. What is the result of a glycolytic enzyme deficiency? And what is the result of a deficiency in pyruvate? So first, what about that glycolytic enzyme deficiency? Well, your red blood cells are dependent on glycolysis for energy. So red blood cell hemolysis is the result there. And then what is the result of a deficiency in pyruvate dehydrogenase? Well, primarily with this one, you get neurologic defects. All right, guys, that brings us to the end of the warm-up. Let's get to that lecture now.
In this video, we're continuing our discussion of anemias. And remember, we're dividing up the causes of anemia based on the size of the red cells. So we discussed microcytic anemia, where the red cells are smaller than normal, in a previous video. And in this video, we'll discuss macrocytic anemia, where the red cells are larger than normal, and also normocytic anemia, where the red cells are normal in size. There just aren't enough of them. So let's start with macrocytic anemia, where the MCV is high and the red cells are too large. We can divide macrocytic anemias into megaloblastic anemia, which is due to impaired DNA synthesis, and non-megaloblastic anemia. Now, it's not always easy to distinguish between them because there can be some overlap. The main causes of megaloblastic anemia are B12 deficiency and folate deficiency. Now, megaloblastic anemia is due to impaired DNA synthesis. And because you have trouble making DNA, it takes a long time for the nucleus of the red cell precursor to mature, and the cytoplasm expands in the process and the red cells just get larger and larger. Now, one important clue that you're dealing with megaloblastic anemia is the presence of hypersegmented neutrophils, meaning the nucleus of the neutrophil has more than 6 lobes. So if they show you a smear with big red cells and then off in the corner is this lonely little neutrophil, you might tend to ignore it. But if you notice that the nucleus has more lobes than normal, think about megaloblastic anemia. And folate and B12 deficiency can also sometimes cause glossitis, or inflammation of the tongue. B12 deficiency can cause neurologic defects like peripheral neuropathy and also dementia. Folate deficiency won't cause those. That's a very important distinguishing point. Both B12 and folate deficiency will cause elevated homocysteine, but with folate deficiency, methylmalonic acid will be normal. With B12 deficiency, methylmalonic acid will be increased. That's another good clue. But fundamentally, how do you determine which is which? So if you have a patient with megaloblastic anemia, you're going to suspect either folate or B12 deficiency. How do you tell them apart? In practice, you're just going to check a B12 or folate level. The causes of folate deficiency are things like malnutrition, especially in alcoholics who are living on booze and aren't eating very well. Also malabsorption, medications that interfere with folic acid metabolism like methotrexate or trimethoprim. Or if you have a high folate requirement like hemolytic anemia or pregnancy, that might lead to folate deficiency. Now, what kinds of things cause B12 deficiency? Well, it's a lot of the same things. Malnutrition, again, especially in strict vegans, they have to take B12 supplements. Malabsorption, including pernicious anemia, Crohn's disease, and also the fish tapeworm Diphyllobothrium latum can cause B12 deficiency. Then one other quick point is that if you have someone with megaloblastic anemia, you don't want to treat with folic acid empirically, although that's actually the most common vitamin deficiency in the U.S. It's tempting just to start some cheap, safe, over-the-counter folate pills. But the problem is that empiric treatment with folic acid, it may correct the anemia, but if there's also B12 deficiency, that folate isn't going to treat the B12 deficiency, and you can still get all those neurological problems from the underlying B12 deficiency. Earlier in the course, we also discussed one type of megaloblastic anemia that is not correctable by giving B12 or folate. Remember what that was? Orotic aciduria. We talked about orotic aciduria as a disease related to the deficiency of the enzyme UMP synthase, which is involved in pyrimidine synthesis, where you get orotic acid in the urine and megaloblastic anemia, but you do not see hyperammonemia. Hope that sounds familiar. If not, you should probably go back and review that. And then what about macrocytic anemia? That's not classified as megaloblastic. So most of the time when you see macrocytosis, it's going to be megaloblastic anemia, but sometimes it's not. So what are the kinds of things that cause macrocytic anemia where you don't have those hypersegmented neutrophils like you do with B12 or folic acid deficiency? Well, you can see that with liver disease or with alcoholism due to bone marrow suppression. So here's where we get some overlap. Alcoholism can lead to B12 or folate deficiency and megaloblastic anemia, but alcoholism can also be a cause of macrocytic anemia by itself without the megaloblastic component. So make note of that. And then certain drugs like 5-fluorouracil, which is an anti-cancer drug, and also zidovudine and hydroxyurea. Those are all potential causes of macrocytic anemia that is not megaloblastic anemia. So we've talked about red cells that are too small. We've talked about red cells that are too big. So what about anemia where the cells are just right? Well, that's called normocytic anemia. You can split normocytic anemia into two major groups, hemolytic anemias and non-hemolytic anemias. We're going to talk about the hemolytic anemias in the next video. But for now, let's just talk about the non-hemolytic anemias. And that differential is pretty short. There's anemia of chronic disease, which we mentioned earlier with the microcytic anemias, because anemia of chronic disease commonly causes normocytic anemia, but then it could eventually cause microcytic anemia. So let's add just a little bit more detail about anemia of chronic disease. So when you have inflammation, you have a lot of inflammatory mediators like IL-6. They're going to cause the liver to make this hormone called hepcidin. And that inhibits something called ferroportin in the macrophages so that iron gets trapped in the macrophages. So you have plenty of iron, but it's trapped and you can't get it to the red cell precursors in the bone marrow. So again, you see low serum iron, low TIBC, and normal or high ferritin. Moving on then to aplastic anemia. Aplastic anemia is where the marrow just gives up and quits making cells altogether. So you might see pancytopenia, or failure of the marrow to make any cell lines. So you can have anemia, leukopenia, and thrombocytopenia. No red cells, no white cells, no platelets. And you definitely need to know the histology of aplastic anemia. You have hypocellular bone marrow with fatty infiltration. So if on your test you see a bone marrow and it's filled with adipocytes, you know you're dealing with aplastic anemia. The symptoms are pretty much what you'd expect. The patient has anemia, so that's going to cause fatigue, malaise, and pallor. They have thrombocytopenia, so they can have purpura and petechiae and some bleeding. And then with leukopenia, you can see infections. So you can see how these different cell lines are going to cause slightly different clinical presentations. Then, what causes aplastic anemia? Well, the main thing to know is that radiation causes aplastic anemia. So cancer patients that receive radiotherapy can get aplastic anemia. Exposure to benzene can cause it. Certain drugs can cause it also, things like chloramphenicol, and cancer drugs like the alkylating agents and antimetabolites. Viral infections like parvovirus B19, Epstein-Barr virus, and HIV can all be associated with aplastic anemia, particularly in sickle cell patients. They're just particularly sensitive to some of these viruses. Fanconi anemia, which is different from the kidney disease called Fanconi syndrome. This is Fanconi anemia, which is caused by an inherited defect of DNA repair. And then also idiopathic aplastic anemia. So we don't know what causes it, it just happens. And that can follow acute hepatitis. And then finally, what's the treatment of aplastic anemia? Treatment's not too important for step one, but you need to stop the offending agent if there is one. Sometimes we use immunosuppressants, transfusions as needed, and you can give one of the granulocyte macrophage colony stimulating factors like GCSF or GM-CSF to help stimulate the bone marrow. And then a bone marrow transplant would be an option if the patient isn't responding to anything else. And then the last cause of normocytic non-hemolytic anemia is renal failure. So the kidneys normally make erythropoietin, but if the kidneys are shut down, they're not going to make erythropoietin. So renal failure patients often require regular erythropoietin injections. So again, if you can kind of lump these diagnoses together into the appropriate categories, remember the big picture, remember the softball stuff like classic presentations, you should do just fine with anemia. For instance, if the question stem says anemia and then the bone marrow is filled with adipocytes, that's going to be aplastic anemia. If the question stem says that there's anemia with hypersegmented neutrophils and neurologic symptoms, it's B12 deficiency. So you just have to have certain key points tagged in your mind to each of these specific causes of anemia. All right, now it's time for your end of session quiz. First question, what are the causes of aplastic anemia? So radiation was the big one, then also think about benzene, and there are several drugs that can do it, such as chloramphenicol and cancer drugs. Remember, chemo commonly causes anemia and leukopenia. Viruses like Epstein-Barr virus and parvovirus-19 can cause it, and so can Fanconi anemia. Next, a patient's diagnosed with a macrocytic megaloblastic anemia. What's the danger of giving folate alone? Well, the problem is that if the patient has anemia due to both folate and B12 deficiency, starting folate alone may correct the anemia without correcting the B12 deficiency. Then the patient might end up getting a peripheral neuropathy. So we give folate with B12 to these patients. And then the last question says, what is the cause of anemia given each of the following statements? Now, this is a review of anemias that we covered in this video and the previous video. So microcytic anemia with swallowing difficulty and glossitis is classic for Plummer-Vinson syndrome, which is associated with iron deficiency anemia. Microcytic anemia with greater than 3.5% hemoglobin A2 is beta thalassemia minor. Macrocytic anemia plus hypersegmented neutrophils is megaloblastic anemia, which is most commonly due to B12 or folate deficiency. Megaloblastic anemia that's not correctable by B12 or folate supplements, you're going to think about orotic aciduria. Megaloblastic anemia plus peripheral neuropathy, think about B12 deficiency. Microcytic anemia with basophilic stippling is most commonly lead poisoning. Microcytic anemia that's reversible with B6 supplements is sideroblastic anemia, which we said has several different causes. An HIV-positive patient with macrocytic anemia, remember zidovudine could do this. So this patient may be on zidovudine causing a macrocytic anemia. And normocytic anemia with elevated creatinine is chronic kidney disease resulting in low erythropoietin levels. That's it for this video. I'll see you next time.
Good evening, students, and thank you for tuning in to Ask Dr. Acula with me, Dr. Acula. Tonight's episode is on a topic that is close to my heart, if I had one. Blood drugs. The first question comes from Jill from Ohio. What is the characteristic appearance of red blood cells in a patient with iron deficiency anemia from chronic blood loss? It's a great one, Jill. The answer is hypochromic and microcytic. Now, our next question came off our new message board from user First Year Sucks. What are the clinical uses of erythropoietin? Another good one. The answer is anemia caused by end-stage renal disease, anemia caused by HIV infection, and anemia in some cancer patients. It doesn't work, however, on anemia caused by the undead who feed upon the living. Thank you again for joining me. And remember, your exams don't have to suck. Unless, of course, you're me.
It's time for another warm-up. Let's get going. First question here, a deficiency of which vitamin results in gum bleeding, bruising, anemia, and poor wound healing? So this is going to be classic scurvy, which is vitamin C deficiency. Next, what disorder is associated with each of the following findings? So we have hypertension, hypokalemia, metabolic alkalosis, that's going to be hyperaldosteronism. Fever, night sweats, weight loss, these are your B symptoms of lymphoma, maybe tuberculosis. Adrenal hemorrhage due to meningococcemia, that's going to be Waterhouse-Friderichsen syndrome, which leads to adrenal insufficiency. Blue sclera, that's going to be seen with osteogenesis imperfecta. hyperphagia, hypersexuality, hyperorality, and hyperdocility. That's going to be Kluver-Bucy syndrome, which is a bilateral amygdala lesion. Nystagmus, intention tremor, scanning speech. So that's going to be the Charcot triad of multiple sclerosis. Lower extremity purpura, arthralgias, and renal disease. That's going to be Haydock-Scholin purpura, which is a type of vasculitis. All right, guys, that brings us to the end of our warm-up. Let's get to that lecture.
This is our last video on anemia. Now, we've been categorizing the various causes of anemia based on the size of the red cells. We talked about microcytic anemias and macrocytic anemias, and we said that normocytic anemias could be further split into the hemolytic anemias and the non-hemolytic anemias. So, in this video, we're just going to talk about causes of hemolytic anemia. Now, there are a couple of different ways you can think about hemolytic anemias. You can talk about whether the hemolysis is due to something intrinsic to the red cells themselves, such as sickle cell disease or G6PD deficiency, or whether there's something pathological going on outside the red cells, and we call that an extrinsic problem. Or you can look at where the hemolysis takes place. Is this intravascular hemolysis, where the cells are being destroyed within the vessels themselves? Or is this an extravascular hemolysis, where the red cells are being removed from circulation and then lysed, maybe by the spleen? Now, neither of these divisions is the absolute right way to do it, but it provides a convenient framework for understanding hemolytic anemia and to start to see some similarities between these diseases. So, intravascular hemolysis will lead to decreased serum haptoglobin. Haptoglobin is a circulating protein that binds up free hemoglobin in the blood so that it can be recycled. So, if there's massive intravascular hemolysis and you release a bunch of hemoglobin all at once, the circulating haptoglobin will bind to the hemoglobin, and the free haptoglobin will decrease. So that could be a useful test to order. Another lab you'll often see with hemolysis is an elevated LDH, or lactate dehydrogenase. And we talked about LDH in biochem as the enzyme that converts pyruvate to lactate and back again. So red cells have a lot of LDH, and so do cardiac myocytes. When those cells are damaged, LDH is released into the blood. So high LDH is often seen with hemolysis, but LDH can be elevated in both intravascular and extravascular hemolysis, so it's not necessarily very helpful. And what about bilirubin? Remember, hemoglobin is broken down into bilirubin. So if you have intravascular hemolysis, you would expect haptoglobin to bind up all that hemoglobin before it got broken down. But elevated unconjugated or indirect bilirubin could indicate extravascular hemolysis, and that can lead to some jaundice. So what kinds of things might cause intravascular hemolysis? Well, autoimmune hemolytic anemia is an important one. We're going to talk about that in detail in a moment. Back in immunology, we talked about paroxysmal nocturnal hemoglobinuria, which is generally pretty rare. You can also see intravascular hemolysis due to mechanical destruction of red cells. So this is a good example of an extrinsic cause of hemolysis. The red cells are perfectly normal, but something extrinsic to the red cells is causing them to be destroyed. So if you have aortic stenosis and a lot of turbulence that results from that, that can tear up red cells. Or prosthetic valves can crush some of the red cells. And then what diseases cause extravascular hemolysis? Well, there's hereditary spherocytosis. In that case, the spleen is going to recognize these abnormal, dysfunctional cells. Those cells are going to get pulled out of circulation and then destroyed by macrophages in the spleen. Extravascular hemolysis is also seen in G6PD deficiency, where the red cells are sensitive to oxidative damage. That's actually going to cause both extravascular and intravascular hemolysis. Pyruvate kinase deficiency causes extravascular hemolysis, and so do sickle cell disease and hemoglobin C disease. So let's dive in and look at some of these more closely. We're going to start with the intrinsic hemolytic anemias, or sometimes they're called intracorpuscular hemolytic anemias. Again, there's something inherently wrong with the red cells themselves that makes them more prone to hemolysis. I mean, hemolysis is sort of an occupational hazard for red cells, but on average, we said that red cells tend to survive around 120 days. But if the red cells are defective so that they only survive 90 days or 60 days or 45 days or whatever, that's going to present as anemia because there's a limit to how fast the marrow can produce replacement red cells. So one intrinsic cause of hemolytic anemia is hereditary spherocytosis. This is a defect of the proteins that interact with the red blood cell membrane and the cytoskeleton, mainly ankyrin and spectrin. We said earlier that spectrin is the protein that helps give red cells their biconcave shape, and it allows the red cells to be able to change shape slightly and squeeze through the narrow capillary beds. There are also proteins called band 3 and protein 4.2 that interact with ankyrin to link the cytoskeleton to the plasma membrane. So defects or deficiency of any of these proteins can cause hereditary spherocytosis. And the red cells are going to be shaped kind of like spheres. So on the peripheral smear, the red cells are smaller than normal and they lack the normal central pallor because, again, these are spheres instead of those normal biconcave discs. The CBC will show increased MCHC, which is the mean corpuscular hemoglobin concentration. So think about that. These cells contain the same absolute amount of hemoglobin as normal red cells, but they're somewhat smaller, so the hemoglobin in the cells is more concentrated. The RDW is also increased. That's the red cell distribution width. With hereditary spherocytosis, some of the red cells are smaller in size and some of them are larger in size. There's more variability in the size, and that variability translates to a higher RDW. That's what RDW tells you, how much variability there is in the size of the red cells. Higher RDW means a lot of variability in size, and a low RDW means that the cells are very uniform in size. Now, the reason hereditary spherocytosis causes hemolysis is that the spleen recognizes these red cells as abnormal and then removes them from circulation. So clinically, that's going to lead to splenomegaly because the spleen is working overtime, pulling all these abnormal cells out of circulation, and the spleen gets enlarged. Obviously, hemolysis will result in anemia, and the increase in circulating bilirubin can lead to some jaundice and pigmented gallstones. And then besides the hemolysis, these patients can develop aplastic crises due to parvovirus B19 infection, which suppresses the bone marrow. The classic diagnostic test for hereditary spherocytosis is called an osmotic fragility test. So you put these cells in a hypoosmotic solution, and they lyse more readily than normal cells would. So a high percentage of red cells lyse at any given concentration of sodium chloride. So red cells that would not normally lyse at a given sodium chloride concentration do lyse in a patient with hereditary spherocytosis because that normal spectrum structural framework isn't there to keep the red blood cell intact. So again, that's the osmotic fragility test. There are also newer tests that you might see as well. For instance, you can add a dye called eosin 5-maleimide to the red cells, and that's going to normally bind to the band-3 protein. So reduced binding of this dye indicates a band-3 deficiency, and that suggests a diagnosis of hereditary spherocytosis. Then the treatment is mainly supportive. You're going to give folic acid supplements, you're going to give blood transfusions as necessary for hemolysis. Patients with severe hemolysis and anemia can be treated with splenectomy. So you remove the spleen so it's not going to keep destroying the red cells. So you do a splenectomy, and then after the splenectomy, you're going to see Howell-Jolly bodies. Remember, Howell-Jolly bodies are basophilic nuclear remnants in the red cells, which are normally removed by the spleen. If there's no spleen, those red cells are going to make it into circulation. The next intrinsic cause of hemolysis is G6PD deficiency, and we talked about this in biochem. These are the patients that are sensitive to oxidative stress. So drugs that cause oxidative stress will lead to hemolysis and back pain a few days after they started the drug. Now, do you remember which drugs cause hemolysis in these patients? Let's do a little quiz. Take out a piece of paper and try to list as many of these as you can. I'll wait. Tell you what, I'll even give you a little hint. The mnemonic was spleen purges nasty inclusions from damaged cells. Ring any bells? So I want you to pause the video, try to write these down, and then we'll put up the answers in a moment. Okay, here are the answers. And remember, in G6PD deficiency, you can see Heinz bodies, which are clumps of denatured hemoglobin inside the cell due to oxidation of the iron. And then the macrophages come along and remove the Heinz bodies, which leaves behind bite cells. Pyruvate kinase deficiency is another cause of intrinsic hemolysis. We mentioned this one in biochem also as a glycolytic enzyme deficiency. So with pyruvate kinase deficiency, you can't generate ATP, so you can't maintain the sodium-potassium ATPase, so you're going to get red cell swelling and hemolysis. Paroxysmal nocturnal hemoglobinuria is another cause of hemolysis, and again, we discussed this in immunology. This is where the red cells are missing the surface markers CD55 and CD59, so that complement attacks those red cells and lyses them. So do you remember what the test for PNH was? The classic test is called Ham's test, where you add some acid and you lower the pH, and that activates complement and lyses the red cells. So a positive Ham's test is where you have red cell lysis at a low pH. But that test isn't really used much anymore. Nowadays we do flow cytometry. Another important intrinsic cause of hemolysis is sickle cell disease. The hemoglobin S mutation is a single amino acid replacement in the beta globin gene on chromosome 11 in which valine is used instead of glutamic acid at position 6. We mentioned that previously. Now that mutation allows the hemoglobin to polymerize within the red cell, and those polymers stretch the red cells into that classic sickle shape. So when does this happen? What triggers sickling? Hypoxemia, dehydration, and acidosis are all important causes of sickle crisis. It's very important to maintain adequate hydration, especially during illness, to prevent sickling from taking place. About 8% of African Americans are heterozygous for the hemoglobin S mutation. We call that heterozygous state the sickle trait. And then about 0.2% are homozygous, and they have true sickle cell disease. So heterozygotes are relatively resistant to malaria. That's also true of G6PD deficiency and possibly thalassemias. Newborns with sickle cell disease are initially asymptomatic because they have more hemoglobin F. But as they get older, that hemoglobin F is replaced with hemoglobin S, and they start to have problems and complications. So they can have something called a splenic sequestration crisis, where those sickle cells are getting sequestered in the spleen. And that's going to cause the H&H to drop precipitously. So this is in infants and toddlers in the first 2 or 3 years of life. You might start to see some wedge-shaped infarcts in the spleen on CT. And then eventually the spleen is just totally infarcted by the age of 3 or 4. We call this autosplenectomy. So these patients have no functional spleen, and with that they have increased risk of infection by encapsulated organisms. So these patients need to be immunized against encapsulated organisms like meningococcus and pneumococcus. And it's a good idea to give these patients a flu vaccine every year as well. Salmonella osteomyelitis is more common in sickle cell patients. That's a classic test question. A sickle cell patient comes in with osteo, what's the organism? Salmonella. They can get aplastic crises due to parvovirus B19 infection, just like we saw with hereditary spherocytosis. These patients can have pain crises, which are due to vaso-occlusion. So the cells are sickling in the tissues and the organs. And whenever you occlude something, it becomes very painful because it's ischemic. Now this can take on different forms, like sickling in the fingers, which is called dactylitis, or something called acute chest syndrome. And then you can see renal papillary necrosis due to hypoxemia in the kidneys. In general, the renal papillae are more sensitive to this hypoxia. And then one other incidental clinical finding is that hair-on-end appearance of the X-ray of the skull from marrow hyperplasia, just like we saw with beta thalassemia. So the marrow is churning out new red cells to make up for the ones that get hemolyzed. And then how do we treat sickle cell disease? Well, we can give hydroxyurea, which is going to increase production of hemoglobin F. And ultimately, bone marrow transplantation would be definitive therapy to give new stem cells that don't have that hemoglobin S mutation. Then let's also touch on hemoglobin C disease, which is similar to sickle cell in terms of being a point mutation on the beta globin gene, but here you have a lysine substituted for glutamic acid. Now, this isn't as severe as sickle cell because those hemoglobin C molecules form hexagonal crystals in the cell instead of forming those long polymers. So you might be heterozygous for hemoglobin C, which is asymptomatic, just like sickle trait heterozygotes. Or you might be homozygous for hemoglobin C, which is milder than sickle cell disease, just a little hemolysis and a little splenomegaly, but even that's pretty rare. What you might run across is heterozygotes that have one hemoglobin S mutation and one hemoglobin C mutation. We call this SC disease. Now this is also milder than plain sickle cell disease. There are actually a whole bunch of these really rare hemoglobin mutations, but you're not likely to be tested on them. But SC disease is one you might actually see in practice. So real quick, let's take a look at how we use hemoglobin electrophoresis to diagnose sickle cell and hemoglobin C and all these different combinations. Hemoglobin is a protein, so you can put a patient's hemoglobin in an electrophoresis gel on the left and apply an electrical current, and the hemoglobin is going to migrate toward the positively charged anode from left to right on this image. So if all the hemoglobin migrates all the way to the right, that's a normal adult with all normal hemoglobin A. Neonates still have a fair amount of hemoglobin F, and hemoglobin F is slightly more positively charged, so it doesn't migrate quite as far to the right. So in a neonate, you see a band for hemoglobin A and a band for hemoglobin F. Now hemoglobin S in a sickle cell patient is even more positive because you've replaced a negatively charged glutamine residue with a neutral valine residue. So the hemoglobin S band is even farther to the left, toward the negative terminal, the cathode. So in patients with sickle trait, you're going to see a hemoglobin A band and a hemoglobin S band. And then in patients with sickle cell disease, they're going to have essentially all hemoglobin S because they're homozygous. In the same way, hemoglobin C is more positive still because here that negative glutamine has been replaced with a positively charged lysine. So the C band is even farther to the left. That means that in hemoglobin C trait, you can have an A band and a C band. In hemoglobin C disease, which is homozygous for hemoglobin C, you're going to have one big C band. And then in SC disease, you're going to have an S band and a C band. So if they give you an image of a hemoglobin electrophoresis gel on your exam, you need to know the order of these bands, and then by figuring out which bands the patient's hemoglobin migrates to, you can figure out the genotype and make a diagnosis. Next, let's talk about the extrinsic or extracorpuscular hemolytic anemias. Again, it's called extrinsic because it's something outside the red cell that's causing the hemolysis. We're going to breeze through some of these pretty quickly and then spend the bulk of our time on autoimmune hemolytic anemia, which is something you're probably going to be tested on. The first extrinsic cause of hemolysis is called microangiopathic anemia. This is where the red cells are mechanically damaged as they pass through the lumen of an obstructed or narrowed blood vessel, like in DIC or TTP-HUS, possibly in lupus or malignant hypertension. I mentioned this when we talked about schistocytes. This is mechanical destruction of red blood cells. Basically, you force the red blood cell to be chopped up by fibrin strands, or in the case of malignant hypertension, by extreme shear forces. So again, schistocytes are just red cells that have been sliced and diced. Then macroangiopathic anemia is where instead of red cells getting chewed up by microvascular conditions, here you have damage to the cells by forces in larger vessels. So we said that prosthetic heart valves can do this, or maybe, rarely, aortic stenosis can do this. And then there are some infections of the red cells that can cause hemolysis, like malaria or babesiosis. These are covered in the microbiology lecture on protozoal diseases. Then finally, we're ready to discuss autoimmune hemolytic anemia, which means that autoantibodies are binding to the red cells and causing cell lysis. So we divide these autoantibodies into warm agglutinins and cold agglutinins. Warm agglutinins are IgG antibodies that attach to the red cells and cause them to clump together or agglutinate. Now you can see this with lots of different diseases like lupus and CLL, and lots of different drugs will induce warm agglutinins. And cold agglutinins are IgM antibodies, and they do the same thing, but the difference is they only cause problems when the temperature is lower, so it happens in the cold. Now, one way to remember that cold agglutinins are IgM antibodies is to remember that IgM forms pentamers in circulation, which kind of resemble snowflakes. Let's take a look at the study guide. Cold agglutinins are antibodies against red blood cells that interact more strongly at low temperatures than at high temperatures. They're nearly always IgM antibodies, and they occur regularly in infections with EBV, or infectious mononucleosis, or mycoplasma, and then also some malignancies, such as CLL. So CLL can potentially cause warm or cold agglutinins. Problems occur when there's circulation to a cold extremity. IgM binds the red cell antigen, which leads to complement fixation, and then a membrane attack complex lyses the cell. Warm agglutinins are slightly different. It's also autoimmune, but it's a different antibody. These are antibodies that react against red cell antigens at body temperature. So this can happen spontaneously without needing a cold environment. The second bullet says these are nearly always IgG, and these are seen in four main things. Viruses, such as Epstein-Barr virus and also HIV can do this. So again, EBV can cause either warm or cold agglutinins, just like CLL. Lupus is the second one. The third one is malignancies. So again, CLL, but also non-Hodgkin lymphoma can sometimes cause warm agglutinins. And then the fourth one is congenital immune abnormalities. Then the next question explains the Coombs test. Autoimmune hemolytic anemias will usually have a positive Coombs test. So what's a Coombs test? A positive Coombs test is when there's red cell agglutination that occurs when you add anti-human antibody, because the red cells are coated with either immunoglobulin or complement protein. So basically, the Coombs test is a test looking for antibodies to red blood cells. The direct Coombs test is where prepared antibodies are added to the patient's red blood cells, and then these prepared antibodies are going to bind to antibodies that are on the red blood cells. So you're using an antibody to detect an antibody that's already bound to the red blood cell. If this patient has an autoimmune hemolytic anemia, the red cells are coated with autoantibodies and possibly the complement C3. So you add something called Coombs reagent, which is also called Coombs antiglobulin or anti-human antiglobulin. Basically, Coombs reagent is made of these anti-human antibodies and antibodies that bind human immunoglobulins. Or you can use a type of Coombs reagent which binds to C3. So when you add Coombs reagent, it'll bind to the antibodies and complement on the patient's red cells and cross-link the patient's red cells so that the red cells agglutinate or clump together. So a direct Coombs test is testing for immunoglobulins that are already present on the patient's red cells. We use a direct Coombs test to diagnose hemolytic disease of the newborn, or drug-induced autoimmune hemolytic anemia, and also hemolytic transfusion reactions. Now, the indirect Coombs test is a slightly different test, where the patient's serum is incubated with normal red cells to detect the presence of antibodies. So basically, you're not looking at the patient's red cells this time, you're looking at the patient's serum to see if the serum has antibodies that's going to bind to those normal red cells. So the indirect Coombs test is positive when the patient has antibodies to foreign blood. So this is used to screen blood before transfusion. So you may have heard of type and screen. That's where you take the donor blood and you screen it for the presence of antibodies with this indirect Coombs test. So you could also use this to screen maternal serum for antibodies to a fetus's red cells. So that's it for hemolytic anemia. Now it's time for the end of session quiz. So pause the video, answer those questions, then we'll go over the answers. First question. A child who's been anemic since birth has now been cured with splenectomy. What's the disease? That's hereditary spherocytosis. Next, what findings are associated with hereditary spherocytosis? You're going to see anemia, and then jaundice from the hemoglobin breaking down into bilirubin, because this is extravascular hemolysis that's taking place in the spleen. And then with all that bilirubin, you're more likely to have pigmented gallstones. You might see splenomegaly, and you also see spherocytes on the peripheral smear. You can make the diagnosis with a positive osmotic fragility test or the eosin 5 maleimide test. But Coombs test will be negative because there are no antibodies involved here. Next, what's the difference between the hemoglobin S defect and the hemoglobin C defect? So in hemoglobin S, there's a mutation of glutamic acid to valine at position 6 on the beta globin chain. With hemoglobin C, there's a mutation of glutamic acid to lysine at the same position. And remember, the charge of these different residues is important in separating these different types of hemoglobin into bands on your hemoglobin electrophoresis. Next, what's the difference between a warm agglutinin and a cold agglutinin? So warm agglutinins are typically IgG, while cold agglutinins are typically IgM. Next, what are schistocytes? Schistocytes are fragmented red cells seen on the peripheral blood smear, caused by mechanical destruction of red cells. And the last question. In what hematologic disorder would you find each of the following abnormal tests? So these aren't all hemolytic anemias, but we're lumping them all together because they're all hematologic tests and findings. So Ham's test is the test used to diagnose paroxysmal nocturnal hemoglobinuria. Heinz bodies are seen with G6PD deficiency primarily. Basophilic stippling, you can see this with lead poisoning primarily, and then sometimes in thalassemia and anemia of chronic disease, but again, the main one to know is lead poisoning. And the osmotic fragility test is a test to diagnose hereditary spherocytosis. And then we have some rapid fire facts. So cold temperatures lead to painful cyanosis of the fingers and toes with hemolytic anemia. That should make you think about cold autoimmune hemolytic anemia. Red urine in the morning and fragile red cells, that's paroxysmal nocturnal hemoglobinuria. Basophilic nuclear remnants in red cells, these are the Howell-Jolly bodies that you see in a patient without a functioning spleen. Autosplenectomy, you should associate that with sickle cell disease. That's where the patient autoinfarcts their spleen over several years. And then the drug used to treat sickle cell disease is hydroxyurea. Make sure you know that one. That's it for now. I'll see you next time.
It's time for another warm-up review. Let's get going. A woman develops intense muscle cramps and darkening of her urine after exercise. What is the most likely diagnosis? So this is pretty classic for McArdle disease. Next, which personality disorder best fits each of the following statements? So sense of emptiness and loneliness and impulsiveness, this is a characteristic of borderline personality disorder. Next, we have odd appearance, thoughts, and behavior. No psychosis, though, and social awkwardness. This is going to be schizotypal. Next, we have controlling, perfectionistic, orderly, stubborn, indecisive. That's going to be obsessive compulsive. And then criminality, unable to conform to social norms, disregard for the rights of others. That's going to be antisocial. Next, what substances cause hemolytic anemia in patients with G6PD deficiency? So the mnemonic here is spleen purges nasty inclusions from damaged cells. So that stands for sulfonamides, primaquine, nitrofurantoin, isoniazid, favabeans, dapsone, and chloroquine. All right, that's it for the review. Let's get to that lecture now.
Before we get started, I need to address the elephant in the room, facial hair. Now, I'm not sure why this has become such a controversial subject. First of all, Dr. Lewis struts around here like he's the king of DIT, all because he has a beard. Fine, whatever. And then Dr. Taj Zoy, I can't ever say it. What's his first name? Elmo? Email?
Emil Tajoy.
Dr. Emil Tajzoy. Sounds like a third-rate Bond villain. Anyway, Dr. Oddjob comes along and he starts talking trash about his beard, which is fine. Everybody needs a gimmick, I guess. And I'm really happy for him, and I'm gonna let him finish, but back when I grew a beard, I had one of the best beards of all time. All time. So, if you have to vote on who has the best beard, I think it's pretty clear who wins. Now, in this video, we're going to talk about platelets. We're going to start by reviewing how platelets work, and then we'll review some drugs that affect platelet function. Platelets work hand in hand with the coagulation cascade to produce hemostasis, but we're going to be talking about platelets separate from the coagulation factors so that you can keep those somewhat separate in your mind. So let's start with some platelet basics. Platelets 101. First of all, platelets are derived from precursor cells called megakaryocytes. Remember, megakaryocytes are huge. They're megakaryocytes. And then they pinch off little bits of cytoplasm and cell membrane, which are the platelets. Now, platelets have no nucleus, and they live in circulation only 8 to 10 days. It's tempting to think of platelets as these little inert fragments that don't really do much but plug up holes in blood vessels. But in reality, they're a lot more complex than that. They have several different kinds of glycoprotein receptors, and they contain granules filled with various signaling substances. There's actually a lot going on with the platelets, especially when you consider that since they have no nucleus and no DNA, they can't make any proteins. So let's talk about how platelets work, how they stop bleeding. Platelets work hand in hand with the coagulation cascade. And remember, the end product of the coagulation cascade is a fibrin clot or fibrin mesh. That fibrin clot is the more permanent blood clot. But that takes a little time to form, so the very first step in hemostasis is the formation of a platelet plug. So first you plug the hole with platelets, and then the second step is to activate the coagulation cascade and form the fibrin mesh clot. But the platelet plug comes first. Think about it, if you're in a boat and it springs a leak, the first thing you do is plug the hole quickly, and then you can worry about a more permanent patch. So let the phrase platelet plug remind you that the platelets act first to plug the hole, and then the fibrin mesh is that permanent patch. So when you have an injury to a blood vessel, that leads to platelet adhesion, then platelet activation, and finally platelet aggregation. Adhesion, activation, and aggregation. So first the platelets have to adhere to the injured surface, then they have to become activated, and then they aggregate and clump together to form that temporary platelet plug. So it's important to understand each of these steps, so we're going to talk about each step in detail. So start by looking closely at how platelets interact with the vascular endothelium, the endothelial cells that line the inner surface of the blood vessels. Those endothelial cells contain a lot of important chemicals that play a role in platelet stimulation and thrombogenesis. There's von Willebrand factor, there's thromboplastin, also called tissue factor, there's TPA, which is tissue plasminogen activator, and there's PGI2. But for now, let's focus on von Willebrand factor. Take a look in your study guide. Von Willebrand factor is made up of several subunits that are linked by disulfide bonds, and it's synthesized by endothelial cells and megakaryocytes. Now, we just talked about how megakaryocytes are what make platelets. So platelets have von Willebrand factor inside them, as we're going to see shortly. Then, von Willebrand factor has two major functions. First of all, it complexes with factor VIII and stabilizes it. So a deficiency of von Willebrand factor, which we call von Willebrand disease, is going to look a lot like factor VIII deficiency, which can lead to elevated PTT. And what disease results from factor VIII deficiency? I'll give you a hint. Remember that 8 sounds like A, it's hemophilia A. So just like hemophilia A raises your PTT, so can von Willebrand disease. Then the other major function of von Willebrand factor is that it's involved in platelet adhesion to the vessel wall and to other platelets. This means that deficiency in von Willebrand factor will also lead to an increase in bleeding time. Bleeding time is a test used to measure platelet function. Now, we don't really do bleeding times much anymore, but the basic idea is that you cut the skin and you see how long it takes for the bleeding to stop. Since the platelet plug is what stops the bleeding initially, the bleeding time is a test of platelet function. So bleeding time will be prolonged in anything that impairs platelet function. But again, von Willebrand factor is important for both the coagulation cascade and also for platelet adhesion. So if there's a von Willebrand factor deficiency, the platelets can't adhere to the injured endothelium and they can't form that platelet plug, so bleeding time will be prolonged. All right, so going back to our blood vessel, the thing that kicks off thrombogenesis is some kind of injury to the vascular endothelial cells. When the endothelium is injured, the subendothelial collagen is exposed, and you have some platelets just kind of floating by. Now, when the endothelium was injured, von Willebrand factor and all those other chemicals leaked out of those damaged, ruptured endothelial cells. But we're still focusing on von Willebrand factor for now. Von Willebrand factor is going to bind to that subendothelial collagen. Then it's also going to bind to a glycoprotein receptor called glycoprotein 1b on the surface of the platelet. That's how the platelets begin to adhere to the damaged endothelium. So injury leads to platelet adhesion. The next step after platelet adhesion was platelet activation. And that basically means that the platelets change shape and they grow these long fingers or pseudopods that help them bind tightly to the injury site. And then activated platelets begin secreting lots of important substances. We talked about all the stuff that was found inside the endothelial cells, but remember there's lots of stuff inside the platelets too. Remember, platelets don't have nuclei or a lot of cellular machinery, so they can't make anything, but they come preloaded with several important chemicals. They have von Willebrand factor again, and also some fibrinogen, cyclooxygenase, thromboxane A2, and a lot of other chemicals. These are actually outlined in the study guide under platelet stimulation. The first bullet is adhesion, which is just the first step of platelet stimulation. We just covered that. Then the second bullet is activation. So activated platelets secrete a bunch of stuff. They secrete ADP, platelet-derived growth factor, serotonin, fibrinogen, lysosomal enzymes, thromboxane A2, which as you remember is a prothrombotic substance that's going to induce thrombosis. It's right there in the name, thromboxane. Platelets also secrete calcium, which is needed to activate the coagulation cascade. Several steps in the coagulation cascade require calcium. And platelets also secrete thrombin. And remember that thrombin is the enzyme that converts fibrinogen to fibrin, and fibrin is what forms the fibrin mesh clot. And when the platelets release thromboxane A2, that leads to vasoconstriction and platelet aggregation. So thromboxane A2 comes from platelets, and it also induces further platelet aggregation. So besides forming the platelet plug, activated platelets also release a lot of things that are necessary components of the coagulation cascade, such as fibrinogen and thrombin and calcium. So we had adhesion of platelets, then activation of platelets, and now we're ready to talk about aggregation of platelets. I mentioned a second ago that one of the things that the activated platelets secrete is ADP, or adenosine diphosphate. And on the surface of the platelets, there's an ADP receptor. And when ADP binds to that receptor on the surface of the platelets, it triggers the expression of a glycoprotein 2b3a to come from inside the platelet to outside the platelet. So the ADP receptors basically tell the platelet to start putting glycoprotein 2b3a on the surface of the platelet. 2b3a is very important in allowing platelets to aggregate because the 2b3a on the surface of the platelets is going to bind to the fibrinogen that the platelets released. And that's going to form a series of cross-links between the platelets. This is platelet aggregation. The platelets start to aggregate and form a plug to temporarily stop the bleeding. So the activated platelet basically releases everything it needs to promote platelet aggregation. So that's how platelets work. And understanding these steps will help you understand the mechanisms of various antiplatelet drugs which inhibit platelets at different steps in this process. Let's talk about antiplatelet drugs, starting with aspirin. Aspirin is a type of NSAID, so it inhibits the enzyme cyclooxygenase. Aspirin acetylates both COX-1 and COX-2, so it permanently inhibits cyclooxygenase, and that blocks the conversion of arachidonic acid to thromboxane A2. Now we said that thromboxane A2 will stimulate platelet aggregation. It's thromboxane, so it stimulates thrombosis. So if you inhibit thromboxane synthesis, you're going to inhibit platelet aggregation. Now since aspirin affects platelet function, a patient on aspirin will have a prolonged bleeding time, but PT and PTT are not affected. Lock that in. Bleeding time measures platelet function, not the coagulation cascade. Aspirin is used for a lot of different indications. It's used to reduce fever, it's used to treat pain, it's used as an anti-inflammatory, and it's used as an antiplatelet drug. We give aspirin to patients with an acute MI or acute coronary syndromes to block platelet aggregation and thrombosis of the coronaries, right? Or in an acute stroke. And we give low doses of aspirin daily to prevent MI. Now you need to be familiar with the side effects of aspirin. First of all, any drug that inhibits platelets can obviously increase the risk of bleeding. Inhibition of COX-1 in the GI tract can also increase the risk of peptic ulcers because you're not going to have the protective prostaglandins in the stomach. And you can possibly have some hyperventilation because aspirin directly stimulates the respiratory centers of the brain so that you hyperventilate and you get a little respiratory alkalosis. And we mentioned that when we discussed acid-base disorders in the renal section. But we also said that since aspirin is an acid, eventually that respiratory alkalosis might transition into a high anion gap metabolic acidosis. Another possible effect of aspirin poisoning and salicylate toxicity is tinnitus, or ringing in the ears. And there's also a side effect called Rye syndrome, which is why we generally don't give aspirin to children. Rye syndrome is a type of hepatoencephalopathy. Now, if you remember that name, hepatoencephalopathy, it's going to help you remember the features of Rye syndrome: liver problems and encephalopathy, and also hypoglycemia. Now, what's the one pediatric disease where we do give aspirin? I'll give you a hint. It's a disease that's associated with coronary aneurysms and then also desquamation of the hands and feet. It's Kawasaki disease. Kawasaki disease is one of the few times that we do give children aspirin. Another class of antiplatelet drugs are the ADP receptor inhibitors, or ADP blockers, which include clopidogrel, that's the main one. Then there's also ticlopidine and some newer ones like ticagrelor and prasugrel. So again, these are ADP receptor blockers. So think back to what the platelet ADP receptor does. When ADP binds to the ADP receptor, that induces expression of glycoprotein 2B3A on the surface of the platelets. So if you block that ADP receptor with one of these drugs, you're going to be blocking platelet aggregation. Now, clopidogrel is commonly given during an acute MI, or it can be given for 6 to 12 months following a coronary angioplasty with stenting. It's also used to prevent recurrent strokes. Or if a patient needs to be on aspirin, but he has an aspirin allergy, you might use clopidogrel instead. And then the last drug category of drugs that affect platelets are the glycoprotein 2B3A inhibitors. So there's abciximab, which ends in mab, and that tells you it's a monoclonal antibody. And then the other 2B3A inhibitors are not monoclonal antibodies, and these are tirofiban and eptifibatide. So all these drugs block glycoprotein 2B3A, which was the surface molecule that binds to fibrinogen to cross-link the aggregating platelets. And make note that tirofiban and eptifibatide both contain the letters FIB right in the middle of the name, and that's going to remind us of fibrinogen. So the end result of blocking 2B3A with these drugs is that you inhibit platelet aggregation, similar to the way clopidogrel works, but these actually act on a totally different receptor and at a different step in the process. 2B3A inhibitors are used mainly for acute coronary syndromes, specifically the non-ST elevation MI. So for an ST elevation MI, you might give a thrombolytic like TPA or streptokinase, but for a non-ST elevation MI, you would consider giving a 2B3A inhibitor. They're also used during and after angioplasty. So now we're ready for the end of session quiz. So pause the video and answer those questions, then restart the video and we'll go over the answers together. First question, what's the lifespan of a platelet, which is also the maximum life of platelets after transfusion? It's 8 to 10 days. Next, what molecule is expressed on the surface of a platelet after it becomes activated? It's glycoprotein 2B3A. Next, NSAIDs inhibit the production of which substance important in platelet aggregation? It's thromboxane A2. And the last one, what's the mechanism of action of each of the following drugs? So we've mixed all the antiplatelet drugs and the anticoagulant drugs together in this question for review. So streptokinase is a thrombolytic, which converts plasminogen to plasmin, which cleaves fibrin and breaks down clots. So it lyses clots. It's a thrombolytic. Aspirin irreversibly inhibits COX-1. Clopidogrel blocks platelet ADP receptors. Abciximab is that monoclonal antibody that binds to glycoprotein 2B3A on the surface of platelets. Tirofiban also inhibits glycoprotein 2B3A. Ticlopidine blocks ADP receptors, just like clopidogrel. Enoxaparin is a low molecular weight heparin, which works by inhibiting factor 10A. And eptifibatide is a glycoprotein 2B3A inhibitor, just like abciximab and tirofiban. That's it for now. I'll see you next time.
It's time for another warm-up. Let's get going. First question here, what disorder is associated with each of the following findings? So we have pathology of thyroid cells with optically clear nuclei. So these are your orphan Annie nuclei seen with papillary carcinoma of the thyroid. Next we have anemia with hypersegmented neutrophils. So this is the classic megaloblastic anemia of vitamin B12 and folate deficiency. Branching rods on oral infection, we see that with Actinomyces israeli. Eczema, recurrent infections, and thrombocytopenia. So this is Waiter was a mnemonic for this one for Wiskott-Aldrich syndrome. Hemocistinuria and thrombosis is what you see with paroxysmal nocturnal hemoglobinuria, or PNH. Next, which stage of sleep is associated with each of the following EEG findings? So first we have alpha waves. So this is relaxation, so not really a sleep stage, but you see alpha waves as you are relaxing and about to go to sleep. Stage N1 might have alpha waves, but stage N1 is indicated by one of the answers here, which is theta waves. Beta waves is going to be associated with REM sleep. Delta waves is going to be stage N3. And then theta waves, again, stage N1. All right, that brings us to the end of the warm-up. Let's get to that lecture.
We've talked about how platelets work. Now let's talk about diseases where the platelets don't work, either because there aren't enough platelets or because the platelets that are there are somehow defective. These platelet disorders are very high yield. You should expect several questions on these. First off, how do platelet disorders present? Well, obviously there's going to be bleeding, but specifically you're going to see microhemorrhages. We said that coagulopathies and disorders of the coagulation cascade tend to cause macrohemorrhages, but platelet disorders tend to cause microhemorrhages, such as bleeding from the mucous membranes, epistaxis, which is nosebleeds, and petechiae, which are those tiny little dots on the skin from capillary hemorrhage. They're not raised or palpable, they're just flat brown or red dots, a lot like freckles. Those are petechiae. Or you can have purpura, which are larger hemorrhages under the skin. So microhemorrhages are the classic presentation for platelet disorders. And then on the labs, we've said that since the platelet plug is the first step in hemostasis, with platelet dysfunction, you're going to have an increased bleeding time. But if the coagulation cascade is normal, the PT and INR and PTT should all be normal. Now, there are 4 pure platelet disorders that we're going to discuss, and they're definitely high yield. This is a 4-star topic. You're going to have a question on at least one of these platelet disorders. I want to talk about the 2 more common ones first, ITP and TTP. So the first one is ITP, or immune thrombocytopenia. It used to be called immune thrombocytopenic purpura. Before that it was called idiopathic thrombocytopenic purpura. So you may see those older names from time to time. But this is not an idiopathic disease. This is an autoimmune disease where you have autoantibodies to glycoprotein 2b3a. So these antibodies bind to 2b3a on the surface of the platelets, and then the immune system removes and destroys those platelets. So the platelet count is going to be low. And if you did a bone marrow biopsy, you would see increased megakaryocytes because the bone marrow is trying to churn out more platelets. I also think it's worth knowing how we treat ITP. It's an autoimmune disease, and in general, how do we treat autoimmune disease? We use steroids. So you can use steroids to treat this. You can also use IV immunoglobulin, better known as IVIG. You could also do a splenectomy, so you remove the spleen. Remember, about 1/3 of your platelets are stored or sequestered in the spleen. So if you surgically remove the spleen, that allows more platelets to be in circulation because you're not sequestering them in the spleen. The second platelet disorder I want to cover is TTP, or thrombotic thrombocytopenic purpura. So this is basically a thrombotic disease. The platelets are being excessively activated and they're aggregating, so you're going to have widespread platelet thrombosis. And all that unregulated thrombosis uses up all the platelets, so there's subsequently thrombocytopenia. And then because you've used up all the platelets, you have bleeding and purpura. So again, it's thrombotic thrombocytopenic purpura. Let's look at the pathophysiology in a little more detail because we can tie it into the platelet activation mechanism that we've already discussed. Take a look in the study guide. What's the underlying pathophysiology in TTP? Well, you have a deficiency of a metalloprotease called ADAMTS13. What on earth is that? That stands for a disintegrin and metalloprotease with thrombospondin type 1 motif, number 13. I'm sure that makes it totally clear. This is a zinc-containing enzyme, so it's a metalloprotease, and it cleaves the von Willebrand factor multimers into the smaller active von Willebrand factor units. So remember, when you have an endothelial injury, von Willebrand factor is released. But actually, the von Willebrand factor in the endothelial cells is assembled into large multimers. Then these have to be cleaved into the smaller individual von Willebrand factor units by this ADAMTS13 protease. So in TTP, you have a deficiency of this metalloprotease, so the von Willebrand factor multimers can't be broken down, and these multimers can bind to platelets and cause unregulated platelet aggregation. And again, your platelets are being consumed, so you have thrombocytopenia. Then you also have some activation of the coagulation cascade, and all that excessive coagulation and fibrin mesh within the vessels will cause microangiopathic hemolytic anemia. And we talked about how things like TTP and DIC could potentially cause microangiopathic hemolytic anemia with intravascular hemolysis and schistocytes and elevated LDH. TTP is closely related to another condition called HUS, or hemolytic uremic syndrome. Now, some experts consider these to be two parts of a continuous spectrum of one disease process, while other experts talk about these as distinct entities. But you can think about HUS as being kind of a milder form of TTP. So let's talk about the clinical picture of TTP and HUS together. In the study guide it says, what's the classic triad of findings in HUS and the classic pentad of TTP? So with hemolytic uremic syndrome, you have hemolysis, we just saw that, and it's hemolytic uremic syndrome, so you're going to have some uremia and renal insufficiency. And then you also have thrombocytopenia, because the platelets are aggregating like crazy and they're getting used up. So with both HUS and TTP, you have those three things: hemolytic anemia, uremia, and thrombocytopenia. And then with TTP, you add neurological symptoms, things like confusion, headache, seizures, coma, maybe even some rare focal deficits that look a lot like a stroke, and you add fever. Now, recent studies are suggesting that high fever may actually be fairly uncommon with TTP, but it's still part of that classic pentad. Now, there are several decent mnemonics to help you remember all 5 of those features. One mnemonic is FAT-RN, which lots of students seem to like. FAT-RN stands for fever, anemia, thrombocytopenia, renal failure, and neurological symptoms. And then last year, a student from PNWU came up with the mnemonic HUNT for the toilet paper, where HUNT for is hemolysis, uremia, neurological symptoms, thrombocytopenia, and fever. And then it's HUNT for the toilet paper. So the toilet paper stands for TTP. Not bad. But I prefer the mnemonic nasty fever torched his kidneys, because it talks about fever and talks about torching the kidneys. So that's 2 of the symptoms right there. And you know I love mnemonics that actually mention what you're trying to memorize. So nasty fever torched his kidneys stands for neurological symptoms, fever, thrombocytopenia, hemolysis, and then the kidneys is for kidney failure. But whichever mnemonic you prefer, you need to know that HUS is the milder form with the triad of hemolysis, uremia, and thrombocytopenia, and then TTP is more severe because you've gone from a triad to a pentad. Now, it's relatively rare to see all of those symptoms at the same time. Early on, all you may see is some thrombocytopenia and that microangiopathic hemolysis. Some people will say that if the neurological abnormalities are dominant, it's TTP. If the renal failure and uremia are the dominant presentation, it's hemolytic uremic syndrome. And then one more thing to file away is that in children, HUS is associated with E. coli O157H7 infection. So definitely know that. Our third platelet disorder to discuss is Bernard-Soulier syndrome. Now this one is very rare. About 1 in a million people have it. It's caused by a defect of glycoprotein 1b, which you remember is what binds the platelet to the von Willebrand factor and to the subendothelial collagen. So the platelet can't bind to collagen, there's going to be a defect of platelet plug formation. Now these platelets are also enlarged and they get taken out of circulation, so there's a moderate thrombocytopenia. So the platelet count is decreased and the bleeding time is prolonged. All of these platelet disorders cause prolonged bleeding time, right? But here, the bleeding is actually more of a platelet dysfunction rather than merely a platelet deficiency. With ITP and with TTP, you have that thrombocytopenia. So you can look at the CBC and see that the platelet count is low. But with Bernard-Soulier, the platelet count is only slightly low. The number of platelets isn't too bad, but those platelets that you do have are defective. And then our fourth platelet disorder is called Glanzmann's thrombasthenia. This is a defect in glycoprotein 2b3a. So what platelet process will that affect? Aggregation. Platelet adhesion is normal, platelet activation is normal, but the platelets can't aggregate normally. So here the platelet count is normal, there's no thrombocytopenia. But the bleeding time is still going to be increased because again, without platelet aggregation, you can't form a platelet plug. So bleeding time is prolonged. So again, those are your 4 major pure platelet disorders: ITP, TTP, Bernard-Soulier syndrome, and Glanzmann thrombasthenia. Very high yield. Then I also want to remind you of a couple of other situations where you might have some thrombocytopenia. We talked about heparin-induced thrombocytopenia. We also talked about with aplastic anemia, you can have some thrombocytopenia because with aplastic anemia, the bone marrow stops making everything. Now let's look at some mixed platelet and coagulation disorders. These are diseases that affect both the platelets and the coagulation cascade. Let's start with von Willebrand disease, which is the most common inherited bleeding disorder. It's more common than hemophilia. It's much more common than those other hereditary bleeding disorders we talked about, like Glanzmann thrombasthenia or Bernard-Soulier syndrome. So von Willebrand disease is a defect of von Willebrand factor. We talked about how von Willebrand factor does 2 things. It stabilizes and protects factor VIII, so a von Willebrand factor deficiency is going to increase PTT, and it binds to the subendothelial collagen and to glycoprotein 1b on platelets. So if that doesn't happen, the platelets can't adhere to the vessel wall and you'll have prolonged bleeding time. So that's why this is one of the mixed disorders. It affects both the coagulation cascade and platelet function. Now, to diagnose von Willebrand disease, you can measure the von Willebrand factor level, you can measure the factor VIII activity, or you can do a ristocetin cofactor assay. And that's the diagnosis you're most likely to see on step 1. Ristocetin is a substance that causes platelets to agglutinate if von Willebrand factor is present. So if you take the patient's blood and you add ristocetin and the platelets agglutinate, that means the patient's blood does contain von Willebrand factor. But if there's no agglutination, that's positive for von Willebrand disease. And then the treatment is something you'll never be able to reason out in a million years. You just have to memorize it. For von Willebrand disease, we give DDAVP or desmopressin, which is a synthetic form of antidiuretic hormone. ADH increases the release of von Willebrand factor from storage sites in the endothelial cells. So you give DDAVP, more von Willebrand factor can be released. Then the other mixed disorder is DIC, or disseminated intravascular coagulation. Now DIC is a terrible disease, very, very life-threatening. Like the name suggests, you have this widespread activation of clotting. So you're consuming all your platelets and you're consuming all your coagulation factors. So even though the underlying pathology is coagulation, the clinical result is that you're hypocoagulable, so you're going to have more bleeding, somewhat like TTP in that regard. You have low platelets because they're being consumed, and that causes a prolonged bleeding time. But the coagulation factors are also being consumed, so PT and PTT are also going to be prolonged. This is a real mess. You can also see low fibrinogen, which is a very good clue on the labs, and it's very high yield. Now, why would DIC cause low fibrinogen? Well, because fibrinogen is being used up, just like the platelets are being used up and the other clotting factors. You might see high fibrin split products or high D-dimer. Those are D-dimers or fibrin split products are protein fragments that are left over when you break down fibrin. So your body's having to break down all those widespread clots, and that's going to cause an elevated D-dimer. And then on peripheral smear, you might see schistocytes from that microangiopathic hemolytic anemia. And then you should know clinically DIC can present with bleeding, obviously, and also multi-organ failure. It's important to remember the potential causes of DIC. And there's a good mnemonic for this one too. Stop making thrombi. That stands for sepsis, which is classically gram-negative sepsis, but any kind of sepsis can do it. Trauma, obstetric complications, especially amniotic fluid embolism or abruptio placentae. So anytime you see a postpartum patient with excessive bleeding, think about the possibility of DIC. Acute pancreatitis can cause DIC, so the P is for pancreatitis. And then the M in making is for malignancy, and the T in thrombi is for transfusion. So definitely know those causes of DIC. Stop making thrombi. Again, I love it when a mnemonic is linked to the subject you're learning. Now, for years, this mnemonic has been taught as stop making new thrombi, where that N in new was supposed to stand for nephrotic syndrome, but I haven't been able to find any good data to back that up. Let's wrap up with a whiteboard review. We've covered 6 different platelet disorders in this video. So let's match the underlying pathophysiologies over on the left with the names of the disorders on the right. So the first one, we have anti-glycoprotein 2B3A antibodies, and those are seen in ITP, those patients with immune thrombocytopenia. Then ADAMTS13 deficiency, we said was associated with TTP-HUS. Glycoprotein 1B defects are seen in Bernard-Sillier syndrome. Then glycoprotein 2B3A defects are seen in Glanzmann's thrombasthenia. Then obviously von Willebrand factor defect is associated with von Willebrand disease. And widespread activation of platelets and the coagulation cascade is DIC. So let's also think about which of these diseases are going to present as chronic platelet disorders and which ones are going to be more acute illnesses. So first of all, genetic disorders are generally going to be chronic, right? So which of these are due to genetic defects? Well, von Willebrand factor is generally genetic. That means it's going to be chronic. And so is Bernard-Sillier syndrome and Glanzmann's thrombasthenia. Now, ITP isn't necessarily genetic, but it is a chronic disease. Generally, these patients are going to settle at a stable platelet count without needing any ongoing chronic treatment. But very few of these patients have a true spontaneous remission, so it is a chronic disease. And then TTP and HUS is generally an acute disease. and so is DIC. And both of these have very high mortality unless these are recognized and treated. All right, let's go ahead and tackle the end of session quiz. All right, first question. What is the cause of ITP? Well, it's caused by antibodies against glycoprotein 2b3a on platelets. And those antibodies bind to the platelets, and then the platelet antibody complexes get removed from circulation. Next, what's the defect in Bernard-Soulier disease? That's a deficiency of glycoprotein 1b, so the platelets can't bind to collagen very well. And the last question, after a normal spontaneous vaginal delivery, a new mom bleeds profusely from her vagina and then later from her gums. So what abnormal lab values would you suspect? Well, the gum bleeding is very suspicious. That tells you this is more than just postpartum hemorrhage. This is DIC. Remember we said obstetric complications such as amniotic fluid embolism or placental abruption can sometimes cause DIC. It's very important to be able to recognize DIC from the labs. So the labs are going to show increased bleeding time, increased PT and PTT, decreased platelets, high D-dimer, and decreased fibrinogen. All right, that's the end of the quiz. So let's go ahead and go through these rapid fire facts quickly and then we'll be all done. So antiplatelet antibodies are associated again with immune thrombocytopenia. Bleeding disorder with glycoprotein 1b deficiency is Bernard-Soulier disease. And the most common inherited bleeding disorder is von Willebrand disease. That's it for now. I'll see you next time.
It's time for another warm-up review. Let's get going. What condition is associated with each of the following findings? So first we have focal myocardial inflammation with multinucleate giant cells. So these are the Askoff bodies of rheumatic fever. Next, eosinophilic cytoplasmic inclusions or globules in the liver cells near the nucleus. These are Mallory bodies seen mainly with alcoholic liver disease. Desquamated epithelium casts in the sputum. These are the Kirschmann spirals seen with bronchial asthma. Onion skin periosteal reaction, that's going to be seen in Ewing sarcoma of the bone. Pseudopalisading tumor cell arrangement. This is glioblastoma, which is the most common primary brain tumor in adults. Next, we have elevated serum uric acid. That's going to be seen with gout, Lesch-Nyhan syndrome, myeloproliferative disorders, and also diuretics can cause this like loops and thiazides, which is why we don't give those diuretics to patients with gout. Next, what is the equation for Gibbs free energy? So it's the change in G is going to be equal to change in H minus T times the change in S. Next, what genetic syndrome has each of the following underlying mechanisms? So first we have decrease NADPH due to lack of HMP enzyme. That's going to be glucose 6-phosphate dehydrogenase deficiency. Next we have inherited defect in tubular amino acid transporter. Could be either cystinuria or Hartnup disease. Next we have deficiency in homogentisic acid oxidase. That's going to be alkaptonuria. And then we have blocked degradation of branched chain amino acids. That's going to be maple syrup urine disease. All right, that's it for the review. Let's get to that video.
As we approach the end of the course, I'm sure you're feeling pretty burned out from all the intense studying. That's normal. And I'm sure your thoughts are beginning to wander toward how you're going to celebrate finishing your exam. Getting out of the library, catching up with friends, enjoying nature, reading for fun, living life. But first, you need to ace this exam. So I want to encourage you to stay focused. Push on through to the end. You'll be glad you did. I had a slight boating mishap. So far in hematology, we've talked about hemostasis, we've talked about red cells, we've talked about platelets. So all we have left are the white blood cells. In this video, we'll discuss lymphoma, which is a malignancy of lymphocytes. And then in the next video, we'll talk about leukemia and a few other disorders of white blood cells. Give me a second to freshen up. Much better. Now, where was I? Lymphoma. So what's the difference between lymphoma and leukemia? Well, they're both malignancies of the white blood cells, but the main difference is where the cells are located. Leukemia mainly involves the bone marrow, and then the tumor cells might spill over into the peripheral blood. Lymphoma is where the malignant lymphocytes show up as tumors in the lymph nodes. But still, it's sometimes really just a matter of semantics. For example, there's one type of lymphoma that's identical to a specific type of leukemia. The only difference is whether the malignant cells are found in the lymph nodes or in the marrow in the blood. So let's talk about lymphoma. There are literally about 40 different types of lymphomas, and we divide them into Hodgkin lymphoma, which is just one type, and then non-Hodgkin lymphoma, which are the other 39 types. So there are some different subtypes of Hodgkin lymphoma, but it's still a bit lopsided. And it's somewhat arbitrary to lump all of these very different types of lymphoma into this non-Hodgkin category, but we're stuck with it. So what makes a lymphoma a Hodgkin lymphoma? Well, it's the presence of Reed-Sternberg cells. Reed-Sternbergs are these distinctive-looking, very large cells, and they have multiple nuclei, or bilobed nucleus, and then they have prominent nucleoli with some clearing around the nucleoli so that it looks like a pair of owl's eyes. And then Reed-Sternberg cells can also shrink on the slide so you get this clearing around the cell itself. And you need to be able to recognize a Reed-Sternberg cell. I'd be very surprised if you don't see that on your test. Hodgkin lymphomas are typically found in a single group of lymph nodes, and extranodal involvement is rare. Some of the non-Hodgkin lymphomas can turn up in the brain or the thyroid or other organs, but Hodgkin lymphomas are usually confined to the lymph nodes. These patients will classically have painless, non-tender lymphadenopathy, especially in the neck. These nodes feel firm and rubbery, kind of like squeezing a rubber ball. Patients might also present with lymphadenopathy in the mediastinum, which you can see on chest x-ray or CT. They can also have constitutional B symptoms. So the B symptoms are low-grade fever, night sweats, and weight loss. Now these symptoms might make you think about tuberculosis, but if there's no sign of tuberculosis, think about Hodgkin disease. Pruritus is another common constitutional symptom you can sometimes see, but technically pruritus is not classified as a B symptom. The official B symptoms are fever, night sweats, and weight loss. Now classically, Hodgkin lymphoma has a bimodal age distribution. So you have one peak of incidence around age 20 and then a second peak of incidence around age 65. So think about teenagers and young adults and then older adults. And generally, Hodgkin lymphomas are more common in men, except for the nodular sclerosing subtype of Hodgkin lymphoma. We're going to talk about the different subtypes in a moment. So then what about non-Hodgkin lymphoma? Now, you don't necessarily have Reed-Sternberg cells, but most of these non-Hodgkin lymphomas are B-cell lymphomas of one type or another. Non-Hodgkin lymphoma is also found in the lymph nodes, but it can be in lots of different lymph nodes. It can be very widespread. It can be found in lots of other tissues, like the GI tract or the thyroid, or you can have CNS lymphomas. These can pop up almost anywhere. These generally have fewer constitutional symptoms, fewer of those B symptoms. They're possible, but less classic. Then the age distribution is much more widely variable. Certain types of non-Hodgkin lymphoma sort of fill up the valley between those two bimodal peaks you see in Hodgkin lymphoma. But other types of non-Hodgkin lymphoma are more prominent in the very young. Some types are prominent in the elderly. Again, non-Hodgkin lymphoma is an arbitrary grouping, so it's a little harder to make generalizations. Then the other thing that you should know is that certain types of non-Hodgkin lymphoma can be associated with HIV and with immunosuppression. Let's go back and talk about the major subtypes of Hodgkin lymphoma. Again, all Hodgkin lymphomas have Reed-Sternberg cells. And in general, if you have a high ratio of lymphocytes to Reed-Sternberg cells, there's a better prognosis. So the more Reed-Sternberg cells you have, the worse the prognosis. But fewer Reed-Sternberg cells is a relatively good prognostic sign. There's lymphocyte predominant or lymphocyte rich Hodgkin lymphoma, which is the least common subtype, but it has the best prognosis. It has very few Reed-Sternberg cells. It's made up of predominantly lymphocytes, hence the name. It's not rocket science. And this tends to occur in younger males. There's nodular sclerosing Hodgkin lymphoma, which is the most common type. It also has great prognosis because it still has relatively few Reed-Sternberg cells compared to the number of lymphocytes. So more lymphocytes, fewer Reed-Sternberg cells means a better prognosis. And if you do a biopsy, you're going to see bands of collagen and sclerosis and fibrosis. So here's a low-power image of nodular sclerosis Hodgkin lymphoma, and you can see the nodules separated by these sclerotic bands of collagen. So it's nodular sclerosis. And I mentioned a moment ago that Hodgkin lymphoma is generally more common in men than in women, but for this one subtype, that's not true, and women and men have a roughly equal incidence. And this one is mainly seen in young adults. Then there's the mixed cellularity type, which is the second most common type of Hodgkin lymphoma. Mixed cellularity means it has a mix of lymphocytes and numerous Reed-Sternberg cells, so this one has a somewhat worse prognosis. Then the last one is called the lymphocyte-depleted subtype. Now here there are lots of Reed-Sternberg cells and not very many lymphocytes, so the ratio of Reed-Sternberg cells to lymphocytes is high and there's a very poor prognosis. Now let's talk about the non-Hodgkin lymphomas, or sometimes that's abbreviated NHL, but that's not the National Hockey League. Anyway, there are about 36 different types of non-Hodgkin lymphoma. I'm not going to try to list all of them. I just want to point out a few high-yield points about a handful of these. I want to start with diffuse large B-cell lymphoma because it's the most common type of non-Hodgkin lymphoma in adults. About 25% of cases of non-Hodgkin lymphoma are diffuse large B-cell lymphomas. It's usually seen in the elderly, and about 30% of these have a translocation 14-18. Now, if the most common non-Hodgkin lymphoma in adults is diffuse large B-cell lymphoma, it's worth mentioning that the one that's most common in children is called lymphoblastic lymphoma. That's probably the only thing you need to know about that one, most common in children. There's also one called follicular lymphoma, which is a completely different lymphoma. And here, more than 90% have this translocation 14-18. Another high-yield one is Burkitt lymphoma. Burkitt lymphoma is associated with translocation 8-14, which activates the c-Myc oncogene. Now, don't get those numbers mixed up. Burkitt lymphoma has 8-14. Follicular lymphoma and diffuse large B-cell lymphoma have 14-18. Watch this. If you write Burkitt like this, so that the B becomes an 8 and the T's become 14, that should help you keep it straight. Pretty cool, huh? In Burkitt lymphoma, you have this classic starry sky appearance, where you have these sheets of lymphocytes, just solid lymphocytes as far as the eye can see. And then you have these scattered macrophages here and there that have ingested the tumor cells. So the dark lymphocytes are the sky, and then the light-colored macrophages are the stars in the sky. Now, there are 3 different forms of Burkitt lymphoma. There's an endemic form, which is mainly seen in Africa. It's associated with EBV, and this will typically involve the mandible. Then there's the sporadic form, which usually shows up in the pelvis or the abdomen. And there's an immunodeficiency-associated Burkitt lymphoma that's associated with HIV. Another type of non-Hodgkin lymphoma is called mantle cell lymphoma. Now this is associated with translocation 11-14. So we had 14-18, we had 8-14, and now we've got 11-14. It's so confusing. But if you draw a line across the ones and you turn the 4 into an A, that can remind you that this is mantle cell lymphoma. That translocation 11-14 ends up disrupting the regulation of cyclin D, so these cells can go right into S phase very, very quickly. Remember we talked about cyclins way back in Foundations. We're going to see them again in oncology. I mentioned earlier that there was one form of lymphoma that was essentially identical to a form of leukemia, and that's called small lymphocytic lymphoma, which is basically the lymphoma equivalent of CLL, or chronic lymphocytic leukemia. The only difference is, again, whether you find the malignant cells in the bone marrow or the lymph nodes. One other type of B-cell lymphoma is called marginal cell maltoma. So remember, malt is that mucosa-associated lymphoid tissue that we typically see in the gut. And if you develop lymphoma in that lymphoid tissue, it might be this marginal cell maltoma. What I want you to remember about this one is that it can be associated with Sjogren's syndrome, it can be associated with Hashimoto thyroiditis, and it can be associated with H. pylori. So those are all types of B-cell lymphomas. Remember, most lymphomas originate from B cells, but there are some that originate from T cells. For instance, there's one called adult T-cell lymphoma. It's a very aggressive cutaneous lymphoma that is caused by human T lymphocyte virus 1, or HTLV1. And there's a cutaneous T-cell lymphoma called mycosis fungoides. It's called that because the dermatologist who first described it thought the lesions looked like mushrooms. Can't make this stuff up. And if those malignant T cells leave those skin lesions and get into the blood, we call that Sézary syndrome. And then there's an intestinal T-cell lymphoma, or sometimes it's called enteropathy-associated T-cell lymphoma, and that's associated with long-term celiac disease. And in celiac disease, you have lymphocytes that are chronically infiltrating the crypts, and those lymphocytes can eventually turn into lymphoma. So that's it for the lymphomas. Again, focus on the classic presentation and the softball stuff. Don't worry about the nitty-gritty detail. Now let's tackle the end-of-session quiz. All right, first question. Compare the age distribution of Hodgkin lymphoma to non-Hodgkin lymphoma. So with Hodgkin lymphoma, you get that characteristic bimodal distribution with one peak around age 20 in the young and the second peak in the elderly around age 65. But non-Hodgkin lymphoma, again, is much more variable, some types being predominant in the young, some in the middle age, some in the elderly. Next, what's the most common type of non-Hodgkin lymphoma in adults and in children? So the most common type in adults is that diffuse large B-cell lymphoma, And in children, the most common is lymphoblastic lymphoma. Next, what form of lymphoma matches each of the following statements? The most common lymphoma in the U.S. is diffuse large B-cell lymphoma. Remember, we also said it's the most common lymphoma among adults, so overall in the U.S. and most common in adults. Reed-Sternberg cells are a feature of Hodgkin lymphoma. Particularly associated with EBV would be Burkitt lymphoma and potentially also Hodgkin lymphoma. Associated with long-term celiac disease is that intestinal T-cell lymphoma. The lymphoma equivalent of CLL is small lymphocytic lymphoma. Starry sky pattern is classic for Burkitt lymphoma. Be sure you can recognize that one. And then the lymphoma associated with Sjogren's syndrome, Hashimoto's, and H. pylori is marginal cell maltoma. All right, now let's go through these rapid-fire facts. The cancer most commonly associated with a non-infectious fever is Hodgkin lymphoma. Remember those B symptoms. Sheets of lymphoid cells with a starry sky appearance is Burkitt lymphoma again. And then large B cells with bilobed nuclei and prominent owl's eye inclusions, those are the Reed-Sternberg cells, which again are seen in Hodgkin lymphoma. That's it for now. I'll see you next time.
These two guys don't get along, but when it comes to education, they are never wrong. Yeah, if you pay attention, you might get an A. They don't like each other, but that's okay, 'cause they are bosom buddies.
Hello everyone and welcome to the show. I'm Dr. Lewis and again, unfortunately, I'm joined by Dr. McGinnis.
Hello.
So let's talk about lymphoma.
Wait. So no intro, no segue, no witty banter. You just want to jump right into cancer.
Well, I didn't have anything planned.
Really? Dr. Funnypants didn't plan anything? Not even something about your stupid beard?
Well, now that you mention it, my beard hasn't gotten much attention lately.
Man, it's like you think you're the first person who ever grew a beard.
Not at all. It's just that I'm the only person who's ever grown such a great beard.
I think I'd rather talk about cancer.
Okay then, but we should really get to the bottom of this beard envy at some point. Now, I'm going to throw out some statements and you match them with the type of lymphoma.
Okay.
Ready?
Yes.
Are you sure?
Just ask the stupid questions, Peach Fuzz.
All right, first one. Starry sky pattern.
Burkitt lymphoma.
Reed-Sternberg cells.
Hodgkin lymphoma.
Most common lymphoma in the United States.
Diffuse large B-cell lymphoma.
Lymphoma most associated with Dr. Lewis's beard.
I'm done.
Nope, it's a beardoma, and it's terminal with the ladies. Wait a minute, that doesn't sound right. It's, how does it go? Man. Well, I guess that's all for today. See you next time. It's time for another warm-up. Let's get going. First question here. A 15-year-old girl of normal height and weight for her age has enlarged parotid glands, but no other complaints. Her mother confides that she found laxatives in her daughter's closet. What is the most likely diagnosis? So this is probably an abuse of laxatives, and the enlarged parotid glands are a clue that she has been vomiting a lot. So she is purging, but she is maintaining a normal weight. So this is bulimia nervosa more likely. If she was underweight, this could be more likely anorexia, but because she is of normal weight, we think more bulimia. Next, which defense mechanism best fits each of the following descriptions? So we have involuntary withholding of a feeling from conscious awareness, so this is going to be repression. A veteran can describe horrific war details without any emotion, this is going to be isolation. A child abuser was himself abused as a child, that's going to be identification. Underlies all other defense mechanisms, that's going to be repression. May lead to multiple personalities, this is going to be disassociation. Adult whining, bedwetting, and crying, that's going to be regression. All right, that's it for the warm-up. Let's get to that lecture now.
Previously on Doctors in Training.
Now, this is a story all about how my life got flipped, turned upside down, and I'd like to take a minute, just sit right there. I'll tell you how I became the prince of a town called Bel Air in West Philadelphia. Born and raised on the playing ground is where I spent most of my days chilling out, maxing, relaxing, all cool, and all shooting some b-ball outside of the pool. When a couple of guys who were up to no good started making trouble in my neighborhood. I got into one little fight and my mom got scared and said, "You're moving with your auntie and uncle in Bel Air." In this video, we're going to talk about leukemias. And all of this will make sense later, but not yet. The first thing you have to understand about leukemia is how we classify it. We classify leukemia based on whether it's acute versus chronic, and then also based on whether the malignant cells are lymphoid cells or myeloid cells. So lymphoid cells are lymphocytes, and the myeloid cells are the granulocytes, like neutrophils and basophils and eosinophils. Now, I'm going to focus on the notes in your study guide as we go through the different types of leukemia. Let's start with acute leukemias. So first of all, what's the difference between acute leukemia and chronic leukemia? Acute leukemia has a rapid onset and is rapidly progressive. In acute leukemia, over 20% of the cells in the bone marrow are blasts, either myeloblasts or lymphoblasts. So if you see a lot of blasts, you know this is an acute leukemia. If they're myeloblasts, that's AML, acute myelogenous leukemia. If they're lymphoblasts, that's ALL, acute lymphoblastic leukemia. But the hallmark is numerous blast cells. And these blasts in the bone marrow eventually spill out into the peripheral blood. So if more than 20% of the leukocytes in the peripheral blood are blast cells, that's an acute leukemia. And acute leukemia is so disruptive to the marrow that it's often associated with pancytopenia as well. So now look at the table. Let's talk about ALL first. The Philadelphia chromosome may be seen with ALL, but typically when we say Philadelphia chromosome, we're talking about CML. Now, we'll talk more about what Philadelphia chromosome is when we get to CML. For right now, just remember that Philadelphia chromosome is CML, but it may be associated with ALL and very rarely with AML. Now, ALL is most common in children and young adults. There are a bunch of morphologic and phenotypic variants of ALL, which thankfully you don't really need to know. Bone pain is common with ALL. There's a good prognosis in children. Up to 90% of children with ALL will have remission. Most malignant cells in ALL are positive for an enzyme called TDT, or terminal deoxynucleotide transferase. That's worth knowing. Positive TDT with ALL. And ALL is relatively difficult to diagnose on the peripheral blood smear alone. The other thing I want you to make note of is that Down syndrome is associated with ALL. So you need to remember that. There's a mnemonic, we all fall down, like Ring Around the Roses. We all fall down, and the all is ALL. So ALL is associated with Down syndrome. And we're going to see in just a second that Down syndrome is also associated with an increased risk of AML. Then over on the AML side of this table, very, very rarely you might see the Philadelphia chromosome. You might see hour rods with AML. That's definitely a high yield point. So hour rods are thin, reddish-pink rods that you see in the cytoplasm of the myeloblasts in AML. So when you see them, think AML. When you see hour rods, think AML. Now these can be seen in any type of AML, but they're especially common in the M3 variety of AML, which is also called acute promyelocytic AML. Again, there are a bunch of different subtypes of AML, which are called M0 through M7, and you don't really need to bother with them. But think about it. Myeloid precursor cells give rise to a bunch of different cell types, like granulocytes and monocytes and red cells, and even megakaryocytes and platelets. So depending on what stage of the myeloid precursor underwent malignant transformation, you might have an AML that makes myelocyte precursors, or AML that makes monocyte precursors, or red cell precursors, or even megakaryocyte precursors. And again, that M3 subtype with our rods is called acute promyelocytic leukemia. That's a subtype of AML. Now, the next bullet in the table says most types of AML are CD13 and CD33 positive. The age of onset is typically around 60 to 65. The median age is actually 65. So ALL is mainly a disease of children, but AML is seen in middle-aged adults or slightly older adults. I like to remember that the myeloid leukemias, AML and CML, occur in midlife. So remember ML for midlife. And then the lymphoid leukemias occur on the extremes of age. ALL is seen in kids, and CLL is seen in the very old. And then AML is associated with numerous risk factors, which are listed in the next question. These are a lot of the same risk factors that we saw with aplastic anemia. Radiation is a big one, benzene, alkylating agents, and myelodysplastic syndromes. I'm not going to read all these to you, be aware of them. And also, you'll notice that Down syndrome is there again. Let's move on to the chronic leukemias. So again, what are the defining features of chronic leukemia? Well, you have insidious onset and gradual progression instead of the rapid onset we saw with acute leukemias. Acute things move very quickly, chronic things take more time. It's pretty easy. With chronic leukemia, there are mature cells rather than all those blasts. So if you see less than 5% blasts, that's chronic leukemia. The way I think about it is this is a chronic process. It takes a long time to develop, so there's a lot of time for these cells to mature. It's not perfectly accurate pathophysiologically, but it's conceptually pretty easy to grasp. And again, if you see mature myelocytes, that's chronic myelogenous leukemia, or CML. If you see mature lymphocytes, that's chronic lymphocytic leukemia, or CLL. So chronic leukemias can be associated with hepatosplenomegaly and lymphadenopathy. Then the bone marrow is going to be infiltrated with leukemic cells, and the peripheral white cell counts may be high. So if you see an older individual with elevated white count, you don't know why it's elevated, think about chronic leukemia as a possible cause of that. Then look at the table. CLL is seen in elderly adults. The median age of diagnosis is 70, and the incidence is higher the older you get. Remember, we said that myeloid leukemias, AML and CML, tend to occur in midlife, but the lymphoid leukemias occur at the extremes of age. So think about CLL in the very elderly. It's certainly not unheard of, though, in the 50s or 60s. Most types of CLL have B-cell markers, so these are going to be B-cell leukemias. And then the characteristic cell in CLL is called a smudge cell. Smudge cells are lymphocytes that instead of having a nice round nucleus, the nucleus is larger and irregular, and the cytoplasm is sort of smeared. It sort of looks like somebody took their thumb and smudged it. So you can also see autoimmune hemolytic anemia with CLL. We talked about that earlier. Now, do you remember which type of autoimmune hemolytic anemia? Does CLL cause warm agglutinins or cold agglutinins? It's both, actually. CLL can cause either one. And CLL tends to be indolent. It means it can last for years and years and years without any real significance. So often we just monitor these CLL patients for progression, especially if they're really old. You know, you got a patient in their 80s, you just monitor the CLL and see if it's going to progress. There's a good chance that they're going to die of some other chronic disease before the CLL actually causes any problem. And then you might make note again that CLL is the same disease as small lymphocytic lymphoma. Which name you give it just depends on where those cells are located. Then over on the right side of the table we have CML. So CML may progress to AML, which is referred to as a blast crisis. So you have a CML patient with mature myeloid cells and various myeloid precursors, and they're just kind of cooking along. Then all of a sudden they start turning out immature myeloid cells, or those myeloblasts, and they've progressed to AML. That's a bad sign, and they need immediate treatment or they're going to die. Now here's a picture of a bone marrow biopsy from a patient with CML, and you see lots of myeloid precursors like promyelocytes and myelocytes and metamyelocytes. But what you don't expect to see is really immature blasts. Now CML occurs in slightly younger individuals, around 25 to 60 years of age, but the average age is around 55. So again, ML is for midlife. And then with CML, the Philadelphia chromosome is always going to be present. We're going to talk about what that is in just a moment. And then you can have fatigue, and abdominal pain, and also splenomegaly. Now we've mentioned the Philadelphia chromosome a couple of times, so let's talk about that for a moment. Philadelphia chromosome is a chromosomal translocation 922, and that translocation occurs at a very specific site which creates a very specific mutation called BCR-ABL, or sometimes we call it BCR-ABL. BCR-ABL is an oncogene. Now we'll discuss oncogenes in the oncology videos, but basically oncogenes are mutated genes that cause cancer. So the BCR-ABL oncogene encodes a type of tyrosine kinase that is constitutively activated. That means it can't be switched on or off. It's just always switched on. It's constitutively activated. And that leads to malignant transformation. So Philadelphia chromosome is always present in CML. We said it's sometimes present in ALL and it's rarely present in AML. So to remember the Philadelphia chromosome goes with CML, I like this mnemonic of Philadelphia cream cheese. And the C and M in cream are for CML. And there's a drug that targets the Philadelphia chromosome called imatinib. It specifically inhibits that BCR-ABL tyrosine kinase. We're going to talk about that in oncology when we cover cancer drugs. Now, there are several other translocations that we've kind of mentioned in passing. Translocation 814 activates the c-MYC oncogene. We said that was associated with Burkitt lymphoma. You remember that handy visual mnemonic. Translocation 1517 is associated with the M3 type of AML, which is the one associated with lots of hour rods. And you can treat that with all-trans-retinoic acid, or ATRA. And I also want you to write in translocation 821. So this is another translocation that can cause AML. And this is why patients with Down syndrome, or trisomy 21, have a higher incidence of AML, because you have an extra copy of chromosome 21, you have more chances of getting this translocation. It just makes sense. Let's briefly discuss myelodysplastic syndromes, which are a pre-malignant, pre-leukemic state. Myelodysplastic syndromes are disorders in which there's dysplasia of the myeloid hematopoietic cells. And again, it's a pre-leukemic state. It's not leukemia yet, but there's concern that it could progress to leukemia, especially AML. Now, just like if you saw cervical dysplasia on a pap smear, you'd be worried that it could progress into cervical cancer. Well, here you have dysplasia of the blood cells, and you're worried that it's going to progress to leukemia. So we keep a close eye on these in case they do become malignant. Now, you might want to be able to recognize this pseudo-Pelger-Hewitt anomaly on the peripheral smear, where the neutrophils have nuclei with two lobes that are connected by a thin strand, so that the nucleus looks like the old-fashioned pince-nez glasses that just pinch the nose like Teddy Roosevelt wore. Most patients with myelodysplastic syndromes are asymptomatic, and the diagnosis is only made after you find an abnormal CBC, and you end up getting a bone marrow biopsy which shows dysplasia and disordered hematopoiesis. Most of the time we simply monitor these patients for progression, or we could treat with transfusions and growth factors as needed. Now we're ready for the end of session quiz, which is just one longish question. So pause the video, write in your answers, and then we'll go through them together. This question says, what form of leukemia matches each of the following statements? So the most common leukemia in children is ALL. Most common leukemia in adults in the U.S. is CLL. Characteristic hour rods is AML, specifically M3 AML. Myelodysplastic syndromes have a tendency to progress to AML. More than 20% of blasts in the bone marrow is an acute leukemia. Leukemia with more mature cells and less than 5% blast would be a chronic leukemia. TDT positive acute leukemia is ALL. Commonly presents with bone pain, ALL. Numerous basophils, splenomegaly, and negative for leukocyte alkaline phosphatase, that's CML. Always positive for the Philadelphia chromosome, that's CML, remember our Philly cream cheese. Acute leukemia positive for peroxidase is AML. Solid sheets of lymphoblasts in the marrow is ALL. And the last bullet, always associated with the BCR-ABL gene. Remember, BCR-ABL is the Philadelphia chromosome, so that's CML again. And now for the rapid-fire facts. Smudge cells are seen in CLL, and reddish-pink rods in the cytoplasm of leukemic blasts are the hour rods, which we said were a feature of AML. I'll see you next time.
It's time for another warm-up. Let's get going. Which enzyme is deficient in each of the following diseases? So first we have fructose intolerance. That's going to be aldolase B. Essential fructosuria is going to be fructokinase deficiency. And classic galactosemia is going to be a galactose 1-phosphate uridyl transferase deficiency. Next question. What is the result of blocking each of the following dopaminergic pathways? So if you block the mesocortical pathway, you have an increase in the negative symptoms of schizophrenia like social withdrawal and depression. If you block the mesolimbic pathway, you relieve the positive symptoms of schizophrenia. So this is a pathway that you are targeting with neuroleptic drugs, so the things like the anti-schizophrenic drugs that are dopamine antagonists. If you block the nigrostriatal pathway, this is going to result in Parkinson's disease. And then stimulation of this pathway can result in extrapyramidal side effects. If you block the last one here, the tuberoinfundibular pathway, you will increase prolactin secretion from the anterior pituitary. So this elevated prolactin causes hypogonadism, which manifests as amenorrhea in women and decreased libido in men, and then rarely can cause gynecomastia and galactorrhea. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to review our final type of hematological malignancy, which is multiple myeloma. Then we'll also review the diseases called myeloproliferative neoplasms, which are non-malignant neoplasms of various types of blood cells. Now, multiple myeloma is the most common tumor that arises within the bone in people over about 50, so it's relatively common. Multiple myeloma is a malignancy of plasma cells. It's a monoclonal plasma cell cancer. Plasma cells are fully differentiated B cells whose job is to produce antibodies. So multiple myeloma is going to produce huge amounts of antibodies, usually IgG, but sometimes IgA. This is a lymph node of a patient with multiple myeloma, and you'll notice that this node is just packed full of plasma cells. Remember, you can identify plasma cells by the little clumps of chromatin in the nuclei that give it what we call a clock face appearance. And then the cytoplasm just outside the nucleus is cleared out. That's called the perinuclear HOF. There are lots of different facets to the clinical presentation of multiple myeloma. The big clues in the initial history in labs would be anemia, renal insufficiency, bone pain, especially in the back, and hypercalcemia. So if you see any combination of those, especially in an older patient, multiple myeloma should definitely be on your differential. Now, to add a little more detail to that, these patients get anemia because all those plasma cells packed into the bone marrow interfere with production of other types of blood cells. One reason these patients get renal insufficiency is that they're producing excessive antibodies that form casts in the urine that kind of plug up the kidneys. That's called myeloma kidney. It's not the only renal pathology you can get with multiple myeloma, but just remember that these patients get renal insufficiency. These patients get bone pain because the myeloma cells secrete cytokines called local osteolytic factors that stimulate osteoclasts and inhibit osteoblasts. So those stimulated osteoclasts are aggressively resorbing bone, and that can lead to microfractures and also hypercalcemia. There are also several findings related to the excessive monoclonal antibody production. Those antibodies are going to show up as a monoclonal antibody spike, or M spike, on the serum protein electrophoresis. Now this is monoclonal. One particular type of plasma cell is being replicated over and over and over, and is making a very specific antibody. And those immunoglobulin light chains also spill into the urine, which we call Bence-Jones proteins. And note this, even though you have these immunoglobulin light chains in the urine, on urinalysis you do not see elevated protein. On your regular UA, you don't see elevated protein. To check for the presence of Bence-Jones proteins in the urine, you have to order a urine protein electrophoresis, or UPEP. Now, myeloma patients have increased susceptibility to infection because even though they make a ton of IgG antibodies, they aren't necessarily the right antibodies, and there's decreased production of healthy lymphocytes and healthy granulocytes to fight infections. And back in immunology, we mentioned that excessive antibody production can lead to one type of amyloidosis. Remember, amyloidosis is where you have deposition of excessive protein, and that protein coalesces into fibrils and then it bulks up tissue. So multiple myeloma can cause amyloid because of deposition of those immunoglobulin light chains. On X-ray, you can see punched out lytic bone lesions on X-ray due to those local osteolytic factors. So you might see an X-ray with lots of hypodense lesions that make the bone look like Swiss cheese. These are the lytic lesions. That's a good diagnostic clue. And then on the peripheral smear, you'll see the red blood cells stacked up like coins or like poker chips, and that's called a rouleau formation. This doesn't actually happen in vivo, it's just something you find on the peripheral smear. You also need to be sure to distinguish multiple myeloma from Waldenstrom's macroglobulinemia. It's similar to myeloma, but with Waldenstrom, you don't have those lytic bone lesions. Waldenstrom causes a monoclonal proliferation of IgM. Myeloma was mainly IgG, Waldenstrom's macroglobulinemia is IgM. And Waldenstrom is also associated with amyloidosis and definitely some hyperviscosity, but no lytic lesions in the bones. I also want to mention plasmacytoma, which is a solid tumor of plasma cells. So there are two different types of plasmacytoma. There's the solitary plasmacytoma of bone, and there's something called the extramedullary plasmacytoma. And one thing to know about the extramedullary plasmacytoma is that it has a predilection for the head and neck region, such as the nose. So these are plasma cell tumors that, instead of being located in the bone, you might find them in the head and neck, and specifically the nose. And again, plasmacytomas do not cause lytic bone lesions. There's also a precursor to multiple myeloma called MGUS, or monoclonal gammopathy of undetermined significance. This is a monoclonal proliferation of plasma cells producing lots of monoclonal immunoglobulins, but without all those symptoms of multiple myeloma. So there's no end organ damage yet. But MGUS can progress to full-blown myeloma, so these patients need to be closely monitored, and then when it turns into myeloma, you need to start treating them. Next, let's talk about an unrelated group of diseases called myeloproliferative neoplasms. You may also see them referred to as myeloproliferative disorders. That's the older name. Myeloproliferative neoplasms are basically diseases in which there's a neoplastic transformation of a single myeloid precursor, and that turns into monoclonal proliferation of mature myeloid cells. So there are three big ones to be familiar with: polycythemia vera, essential thrombocytosis, and myelofibrosis. Now, some people like to lump CML in with the myeloproliferative neoplasms too, because it's a neoplasm of mature myeloid cells. But again, these patients have had a neoplastic transformation of a myeloid precursor, and it just keeps dividing and dividing forever, making more and more of whatever that cell line is. So these could be monocytes and neutrophils, these could be red cells, they could be platelets. These are all cell types derived from myeloid precursors. And these represent a broad spectrum of disease. And there's a lot of overlap between these. So you might just make one cell type, or you might make several different cell types. Now you should recall that CML is positive for that Philadelphia chromosome. These other three tend to be positive for a mutation of a gene called JAK2, which encodes a protein called Janus kinase 2, which is involved in hematopoietic growth factor signaling. So what happens is that a myeloid precursor cell acquires the JAK2 mutation so that the Janus kinase 2 protein is switched on all the time, kind of like we saw with the Philadelphia chromosome. It's just a different kinase signaling pathway. So these myeloid precursors have this switched on JAK2 kinase, and they think they're constantly getting a growth factor signal to make new red cells or new platelets or whatever. So let's briefly look at these disorders one by one. Polycythemia vera is where that JAK2 mutation occurs in a red cell precursor so that it keeps making more and more red cells. So this is a benign neoplasm of red cells with out-of-control red cell production. Now when we talked about erythrocytosis, I mentioned that polycythemia vera is characterized by an increased red cell mass without elevated erythropoietin. Now, you would expect to have polycythemia if erythropoietin is elevated, but with low erythropoietin, that's kind of unusual to have a lot of red cells. Polycythemia vera is associated with findings of plethora, which is a reddening of the face, pruritus or itching, especially after a hot bath or hot shower, splenomegaly, and hyperviscosity of the blood, because all those extra red cells make the blood hyperviscous and sludgy. These patients can have headache due to sludging of the blood. They can also have a rare symptom called erythromelalgia, where the hands or feet get red and swollen and painful because of sludging and clotting in the extremities. Essential thrombocytosis is basically the platelet equivalent of polycythemia vera. So instead of having a lot of red cells, now you have a lot of megakaryocytes that are making platelets. There's a platelet stimulating factor called thrombopoietin, kind of like erythropoietin, but it's thrombopoietin. And with essential thrombocytosis, your thrombopoietin level is low. In other diseases, you might have an elevated thrombopoietin level that causes thrombocytosis, but here, thrombopoietin is low. Now, these patients can have thrombosis because they have too many platelets, or they can have bleeding because the platelets they do have don't work correctly. And myelofibrosis is where you have fibrosis and obliteration of the marrow space. So if you're shown a picture of bone marrow that's infiltrated with adipocytes, we said that's aplastic anemia. But if you're shown a picture of bone marrow that's infiltrated with fibrotic tissue, that's myelofibrosis. The name is very descriptive. And we said earlier that myelofibrosis causes teardrop-shaped red cells. Now it's time for the end of session quiz. So pause the video, answer those questions, then we'll go over them together. First question, what pathology best fits each of the following descriptions? Now, if you don't know anything else from this video, know these. So punched out lytic bone lesions are seen with multiple myeloma. Red cells clumped together like a stack of coins, that's the rouleau formation seen in multiple myeloma. Plethora plus pruritus plus headache is polycythemia vera. Back pain plus anemia plus renal insufficiency plus hypercalcemia is multiple myeloma. Teardrop-shaped red cells are seen in myelofibrosis. And a monoclonal antibody spike is classically a feature of multiple myeloma, but it could also be MGUS or Waldenstrom's macroglobulinemia. And the last one, a patient with anemia, hypercalcemia, and bone pain undergoes a bone marrow biopsy which reveals plasma cells. What's the diagnosis and what may be found on urinalysis? So the diagnosis is multiple myeloma. That's pretty straightforward. But the tricky part of this question is that on routine urinalysis, you're not going to see proteinuria. The patient may have Bence-Jones proteins in the urine, but these don't show up as proteinuria on a routine urinalysis. But if you ordered a urine protein electrophoresis, that would show the monoclonal antibody spike. And that's it for this video. I'll see you next time.